which the pregnant patient which comes with ST elevation MI, thrombolytis and fibrinolysis are not to be used, but PCI-based strategies are to be used. And in cases of severe PE and ischemic strokes, they can be given antithrombotics, but keeping in mind the bleeding tendencies are higher, so the include protocol might be needed in case of planned ECMO for PE or such patients. Coming to the next topic. Nerve management in ICU. This question has come multiple times in our DRN critical care examinations. We can divide the question in such topics like definitions, predictors, scoring, physiological difficult airway. It's a question in itself. Intubation strategies, preparations, complications, and algorithm-based guidelines.
Dr.
So coming to the
Abhinav,
definition,
make it a full screen.
yes,
Make it a full screen.
yeah, sorry. Coming to the definition, typical airway is when a conventionally trained anesthesiologist experiences difficulty with face mask ventilation, tracheal intubation, sclerotic airway, or all of the above, and mandates the need for a surgical airway. The differences in airway management in OT patients versus ICU patients are quite distinct and discrete because the patient physiology is different, the preparation time is different. The airway difficulty compared to the OT patients, the patients that we receive in ICU are quite unanticipated. We get a difficult airway. The environment is very much different. Equipment availability in the OT, it's the control environment, so we have all the instruments that are necessary for managing a difficult airway patient, but it is usually kind of limited or variable in ICU patients. Coming to pre-oxygenation, well, we can adequately pre-oxygenate the patients while managing the elective patients in the OT, but critical ill patients usually have physiological difficult airway, and along with that, they have very low oxygen reserve and a low FRC, so the rapid desaturation occurs despite the pre-oxygenation. Coming to the induction drugs, we can use a variety of induction drugs, but the physiological difficult airway patients in the ICU have a unstable physiology, so drugs, the choice of drugs are quite limited. Coming to the intubation approach, usually standard RSI or awake intubation can be done if it is an anticipated difficult airway, but in ICU patients, the modified RSI is much more common, and sometimes delayed sequence intubation or awake intubation needs to be done depending on the patient's profile. Complication rates in OT patients are quite low, but in ICU patients, the complications are quite high, and usually they carry a high risk. Predictors of the difficult airway is classified as anatomical or physiological. The anatomical, we have the mnemonics, like for the face mask ventilation, the mnemonic is like bones. For the laryngoscopy and intubation, we usually follow the Lemon's law. For the supraglottic airway insertion, we use the rods mnemonic, and for the front of neck access or the Pona approach, we use the mnemonic. I have just mentioned the full form of the mnemonic, so you can go through it. So physiological difficult airway, a small mention of it because it is a long question in itself. So particularly ill patients with severe damaged physiology who are at risk of cardiopulmonary collapse during or immediately after airway management. Usually it can be presented as a pneumonic, like for H it's a hypoxemia like ARDS, pneumonia, asthma, and COPD patients. For O it's the obstructive shock and the circulatory failure, like in sepsis, hypovolemia, pulmonary embolism, RV failure. For P is like profound metabolic acidosis, like decay, lactic acidosis, renal failure. For the M, it usually is the mean arterial pressure, or there is ICP for relative hemodynamic instability. So predictors of difficult airway, we usually use the Mekocha score, where there are three factors: the factors related to the patient, factors related to the pathology, and factors related to operator. It was first proposed by De Jong et al. It was published in JAMA article in the year 2013, where it is a good predictor of easy intubation or difficult intubation, where a score of less than 2 predicts the low score of difficult intubation, or a high score of more than 3 predicts high risk difficult intubation. So it has been found that while managing the patients while seeing the Makocha score, the specificity is around 89%, and the negative predictive value is around 92%. So there is another pre-hospital emergency airway management criteria, which is also known as the Haven criteria, where we see these 7 criteria like hypoxemia, extremes of age, anatomic challenge, vomiters or blood or fluid, exsanguination, and NEC. Where this is a pre-intubation assessment tool. It is quite commonly used in ER settings, but it is developed to predict difficult laryngoscopic view and intubation failure, where more than one heaven criterion has a high chance of difficult intubation, and more than two criteria strongly associated with poor laryngoscopic view and failed intubation. It has got a good specificity of around 80%, but it is less validated in ICU compared to the Bekocha score. The complications that have been seen during difficult airway management are the airway trauma, hypoxemia and hypercapnia, aspiration, hemodynamic instability, failed or delayed intubation, esophageal intubation, trauma, neurological complications, and other cases. Key principles of airway management. These are the 5 or 6 principles of airway management. First one is the anticipate physiological difficulty. In addition to anatomic difficulty, we need to prepare drugs and vasopressors before induction. Prefer video laryngoscopy when available. Use modified RSI to avoid rapid desaturation and team breathing and rule allocation in critical patients, and have a plan BCD like the supraglottic airway devices of picothyroid ready. Intubation strategies, RSI in ICUs, modified rapid sequence with reduced induction doses and hemodynamic support. For the awake fabric intubation in anticipated difficult anatomy feasible, we should always keep it in handy. Video laryngoscope has been mandatory in all the available guidelines. It is the first line used in many ICUs, and use of adjuncts like bougie, stylus, or supraglottic devices, like the intubating elements. Coming to the selection of pharmacological agents, it varies from patient to patient, but usually the drugs which causes less hemodynamic instability can be used to manage patients. The sedatives that are commonly used are ketamine and etomidate, and for the relaxants, we usually use rapuronium as a agent of choice for relaxing patients while intubation. So coming to the RSI, small just about the RSI. This is the 7 PSPs of RSI which we have to put it in notes while writing for RSI. The 7 P's are the preparation, the pre-intubation, the pre-oxygenation, then the pre-intubation optimization, then the paralysis with induction agents like NMDAs, and then positioning, then placement with the proof by using capnometry, and post-intubation management. So drugs for rapid sequence intubation, well, the hypnotics, as we have already mentioned, it is those drugs which cause less hemodynamic instability, like etomidate, ketamine. Propofol is rather not used in such critical care settings because of severe hemodynamic compromise. The neuromuscular agents, it has been long been used as acetylcholine, which is a go-to drug for every other intensivist anesthetists, but because of certain known risks of using acetylcholine, propofol is being used, and of course, Sugammadex is in town, so we can use Sugammadex if at all it's necessary as an antidote. So this is the intubation bundle which has been proposed by Jabber et al. In the year, I guess, 2007, I guess. So this is the update of the Montpellier intubation protocol, because Montpellier is I think it's a university hospital in France where Jabber used to work. This needs to be mentioned while placing the intubation bundle, and has been found that this intubation bundle has a good positive predictive value and good negative predictive value also. So the parameters are the points here are the pre-intubation. We should usually have 2 operators of 4 hands is very much necessary. Preloading associated with early introduction of vasopressors, preparation of long-term sedation. For pre-oxygenation, we should consider upright position like of 20 to 30 degrees elevation. Pre-oxygenation during at least 3 minutes with non-invasive ventilation in case of hypoxemic acute respiratory failure, or we call it as apneic oxygenation. During the peri-intubation period, usually we should use video laryngoscope for intubation procedure if predicted difficult intubation. If no video laryngoscope available, we should consider Macintosh laryngoscopy with Schuyler or bougie. Rapid sequence intubation with etomidate or ketamine and scoline or rapuronium. Then Selix maneuver is kind of controversial because it has not shown to be of any benefit. You can use if required, but it usually distorts the anatomy, so rather not use. And then ventilation in case of oxygenation, desaturation less than 90%. Post intubation should be checked. The tube position should be checked by capnography. Increase vasopressors, especially if the diastolic BP is less than 35 or the systolic is less than 90. Start long-term sedation. Low airway pressure ventilation at the beginning, like low lung productive ventilation. Well, it is controversial, but yeah, it has been mentioned in the update of the Montpellier intubation protocol, and cuff pressure should be monitored and should be maintained within 25 to 30 centimeter water. The changes made. Pre-oxygenation expanded now includes choice of NIV and HFNC or non-rebreather mask. That is, these are the changes that has been updated in the Montpellier protocol, or the Java Retail protocol of the intubation bundle. Fluid loading is individualized. Earlier, it was mentioned that routine 500 ml of fluid should be given, but now it is rather individualized as per the hemodynamic status. Induction drugs, usually short-acting induction agents and high-dose dobutamine are preferred. Celix maneuver as a component still applied with the instruction, as we have already discussed. Adjuncts and silent use are encouraged. Recruitment maneuver after intubation added in some modified bundles to reduce the atelectasis and desaturation and focus more on training and compliance monitoring. And bundle adherence are tracked to improve the outcomes. So this is the All-India Critical Illness Association 2016 guidelines. After this guideline, nothing has been updated at this moment. So, but it's quite validated in all settings. So you can go through it. It's available in Google and Internet. Next, we will go to, as we were talking about apneic oxygenation, because question had come earlier regarding apneic oxygenation. So what is this? Actually, it's the delivery of oxygen in the absence of significant tidal volume. It is used to extend the safe apnea time beyond what can be achieved by pre-oxygenation alone. It is not a substitute for pre-oxygenation, but should always be performed after adequate pre-oxygenation. Excuse me. So coming to the physiology, it is also known as the aventilatory mass flow or apneic diffusion of oxygen. As we know, oxygen moves from alveoli into the bloodstream at about 200 to 50 ml per minute during apnea. Only about of this 8 to 20 ml per minute of carbon dioxide enters the alveoli. This creates the subatmospheric alveolar pressure. We get a gradient, and this leads to continued flow of oxygen into the alveoli, even without active ventilation. With pre-oxygenation, alveoli are filled with 100% oxygen, providing a reservoir. Denitrogenation essential to maintain a carbon dioxide, to maintain an oxygen gradient. So this is the physiology. It has been, I have put the this thing. So you can just go and search it over here. So this is the physiology that they have mentioned, where they have found that continuous positive airway pressure increases the oxygen reservoir, and which we can use in times of apnea. Also, the cardiogenic oscillations are very much important.
Sorry
because,
to
yes, ma'am.
Dr.
Sorry, I got
yes. Thank you. And
Dr.
Abhinav, thoda slow. It's getting very rapid. Thoda aaram se.
Yeah. So this is the physiology we were discussing about the apneic oxygenation, where it involves a mass flow of high FiO2, aided by flushing of dead space, and the generation of positive airway pressure and cardiogenic oscillations. So as the cardiogenic oscillations moves, so it moves steady streamlining of the oxygen, and it increases the oxygen reservoir of the alveoli and the bronchioles. So the device is required a nasal cannula standard, which we use like 50 liter per minute, or high flow nasal cannula for the positive airway pressure, because we know it gives a good amount of oxygenation, and dead space we can fill it up with oxygen. So the advantages of HFNO, like, can provide free oxygenation. It is handy, might be more effective in laryngeal pathologies, and relatively expensive. But the problem is that it's not widely available, and it cannot provide bag and mask ventilation like we do with the ammo bags, and you cannot sample it in oxygen concentration. For the nasal cannula, the advantage is that it's cheap and available, can provide bag and mask ventilation if needed. The disadvantages are that it cannot provide free oxygenation to that extent, and might not be as effective as HFNO in laryngeal pathologies. Procedure is like adequate pre-oxygenation with the inner beam or ventilator circuit. Apply nasal cannula at 50 liter per minute or HFNC. We induce anesthesia and initiate apnea. Then maintenance of the nasal cannula flow and airway patency by giving the jaw thrust or using the nasopharyngeal airway, and continue oxygenation during intubation. The pitfalls to avoid, like inadequate pre-oxygenation, failure to maintain airway patency, and using manual resuscitator with one-way valve as sole method of oxygenation. Benefiting populations are the patients with anatomically difficult airway, in obese patients or in pregnant patients, and in patients with physiological difficult airway, where we need adequate apnea time, because the intubation processes can be quite lengthy at times. So this is a stepwise approach for the use of apneic oxygenation. Step 1, patient selection is mandated, and we need to anticipate the difficult airway. Adequate pre-oxygenation is mandated by using NRBM or ventilation or NIV or helmet mask via the anesthesia circuit. Airway patency has to be maintained during the times of apneic oxygenation by giving a jaw thrust for empty airways, and oxygen delivery is usually While intubation, the oxygen delivery is usually should be maintained by using an HFNO or a nasal cannula. Thank you. Next, we move on to this was the topic. It has come once in our earlier exams, the role of electrical impedance tomography in the ICU. So we can divide it into short periods like definition, principle, rationally for use in ICU, standardization, acquisition, and signal processing, clinical applications of electrical impedance tomography in ICU, strength, evidence, limitations, and recommendations, and future directions. So the definition is like it is a non-invasive bedside imaging technique that continuously measures regional changes in electrical impedance tolerance. Changes in impedance correlate with changes in the lung aeration, ventilation, and to a lesser extent, perfusion. Principle is different body tissues have different electrical impedance or the resistance to an alternating current. Here, field lung has a high impedance or a high resistance, while blood and tissue have a lower impedance. So, an electrode belt of around 16 to 32 electrodes is placed around the chest. A small imperceptible alternating current is passed between the pairs of electrodes, and the voltage difference we usually measure at the remaining electrodes. Using these multiple measurements, a 2D cross-sectional impedance map of the thorax is reconstructed. What it actually shows is the changes in impedance over time, or it is equal to the changes in air or blood content. During the inspiration, the lung impedance, because the lung is filled with air and air content has got a high impedance and high resistance. So lung impedance increases during inhalation, and during expiration, impedance decreases. So this procedure is repeated in real time, and it gives a dynamic image, the 3D reconstructed image of regional ventilation, and with contrast or pulse filtering or perfusion is the software that has been incorporated in the machine. So this is the basic flowchart or diagram, as you can say. The rationale for use in ICU, well, for the ventilation monitoring, it's a real-time bedside imaging of regional ventilation. It detects the inhomogeneity or the heterogeneity or atelectasis or over-distension. For the PEEP and ventilator setting optimization, it guides individualized PEEP titration or balances the alveolar collapse versus over-distension. For the detection and prevention of VILI, for the positioning strategies, it assesses the effect of prone positioning in ARDS and monitors dorsal versus ventral ventilation redistribution. For hearing and extubation, it has been used. For non-invasive respiratory support, it compares the effectiveness of NIV, CPAP, or HFNC, and it optimizes interface or settling selection. And also, it can be used for seeing the perfusion and ventilation perfusion matching. For monitoring during special interventions like recruiting manövers, strong positioning, or ECMO and adjunctive therapies. How standardized acquisition and signal processing. The electrode belt placement initiation has to be in proper place. The belt should be placed transversely between the fourth and fifth intercostal spaces in the parasternal line. If it is too low, there will be diaphragm artifacts, and if it is too high, the dorsal lung underestimation will happen, and the results can be erroneous. So, and the belt should actually be placed in the fourth and fifth intercostal space. If it is rotated, the results are usually erroneous. Appropriate belt size should be is required according to the chest circumference, and good electrode skin contact should be there, and we should use the gel. Calibration signal stability check for at least 1 minute after positioning before starting the measurements. And synchronized recordings, the simultaneous acquisition of EITs with other physiological signals are mandated. How to deal with artifacts and signal quality. Artifacts from the diaphragm motion, patient movement, chest wall changes, electrode contacts loss are a reality, and that must be checked before applying the EIT and weight measurements. And if possible, we should exclude the bad segments. In expiratory lung impedance, stability is influenced by many non-physiological factors. Hence, over long recording should be interpreted cautiously. The image processing should be done by using the filtering and the segmentation of the region of interest. We should usually monitor the defined lung areas and the long lung tissue like the chest wall or the heart. And the region of interest can be dorsal or ventral, and depending on that, we should use several methods where each region of interest contributes equally in terms of tidal impedance ventilation. Clinical applications in controlled magnetic ventilations like peak titration using over-distension collapse method, and other intervention like positional changes like prone positioning, lateral positioning, and it helps actually predict the gas exchange responses and also guides the settings in prone positioning. Detection of valid determinants and spontaneously breathing and weaning patients, actually we can see the changes in the inexpiratory lung impedance and the regional ventilation and the heterogeneity in the ventilation. And we can actually alter the changes in the ventilator by using the EIT methods. VQ matching, the method is the same. We use the EIT, but we use two main methods like the bolus technique, where we use the contrast agents like hypertonic saline, and the pulsatility technique, where we use the cardiac components like the cardiac oscillations, and it is used to measure the perfusion in the ventilation perfusion matching. The bolus, there are two techniques. The bolus technique shows good agreement with the imaging modalities. There is some role of electrical impedance tomography in cardiac output monitoring, where the basic principle is like the EIT detects the changes in the thoracic impedance, not only from the ventilation, but also from the pulsatile blood flow. And by analyzing this cardiac related impedance oscillations in the lung regions, information of the pulmonary perfusion can be obtained. As we mentioned, there are two techniques, the bolus technique and the pulsatility technique. The clinical applications are, it is a bedside continuous estimation of the cardiac output. In fact, it was first used in our space shuttle program in 1976 by NASA people, where they used to measure the cardiac output from the astronauts over there. So regional pulmonary perfusion assessment also helps in detect ventilation perfusion mismatch. It also helps in guiding therapy in shock states, ARDS, and ECMO patients. Strengths, evidence, and limitations. Well, the strength side is a real-time continuous monitoring, no risk of radiation, and it helps individuals' ventilatory settings. But evidence are rather scarce. Meta-analysis evidence suggesting that EIT-based sleep strategies improve respiratory mechanics and potentially clinical outcomes in ARDS, but large randomized studies are still lagging behind and still in research phase. The limitations are spatial resolutions. EIT images are 2D cross-sectional slices, but they with the help of software, they also evaluate the 3D structuring. But this is a calculative value. The standardization is rather variable. The variability in the position of the electrolyte placement and the region of interest definitions can be subjective also. The quantitative calibration converting impedance changes to the absolute volumes like lung volume and cardiac volume is complex, and it requires calibration, and it varies from patient to patient and with disease to disease. Artifacts and patient factors also come into play when we evaluate the results, and the evidence are still scarce. That's what we were discussing. Future directions include adoption of multi-frequency and three-dimensional EIT, machine learning, standardized reporting, and more RCTs are to show the impact on outcomes. Next. Coming to the next topic. Am I audible, ma'am?
Yes.
Next topic. Post-cardiac arrest syndrome and prognostication after cardiac arrest, where post-cardiac arrest syndrome refers to the complex pathophysiological state that occurs following the return of spontaneous circulation after cardiac arrest. It is characterized by multi-organ dysfunction due to global ischemia, perfusion injury, and underlying precipitating cause. The prognosis after OHCA averaging is like around 10 to 20% mortality globally. The pathophysiology, when it comes to the pathophysiology, it has actually four major components. It was discussed in the ACOR guidelines in 2022, where there are four components which are post-cardiac arrest brain injury due to global ischemia, accessory toxicity, and reperfusion injury leading to coma, seizures, and poor neurological recovery. Post-cardiac arrest myocardial dysfunction characterized by reversible myocardial stunning and low cardiac output, systemic ischemia, reperfusion response, generalized inflammatory activation, vasoplegia and capillary leak resembling sepsis, and persistent precipitating pathology like ACS, pulmonary embolism, severe hypoxia, electrolyte disturbance. The clinical features are like altered consciousness, coma following RSC, hemodynamic instability, respiratory failure requiring mechanical ventilation, metabolic derangements like acidosis, electrolyte imbalance, hyperlipidemia, seizures or myoclonus due to hypoxic brain injury. Coming to the management, the ABCD approach in the guideline-directed therapy, as advised by all these guidelines. Well, we have to first manage the airborne breathing, like the mechanical ventilation, targeting saturation of around 94 to 98%, and a PCO2 of around 35 to 45 mg, and oxygen hyperoxia. For the circulation, hemodynamic optimization with fluids, vasopressors, drops, and maintain the maintenance of the MAP of around 65 millimeter of mercury. Targeted temperature management, like the update ACLS 2021 states that the comatose adult survivors of cardiac arrest should receive TTM with a constant monitor target temperature of 30 to 36 degrees centigrade for at least 24 hours. But the 2021 updated guidelines suggest that the prevention of fever after rewarming is strongly recommended, and normothermia with active fever prevention is considered acceptable if cooling is not feasible or risks outweigh the benefits. Based on the guidelines is based on TTM2 trial. So coming to the neurologic care, continuous EEG monitoring is required if seizures are suspected and treat with antiepileptics. The prognostication should be delayed for around 72 hours post-ROSC. For the coronary reperfusion, early coronary angiography and PCI if STEMI or a suspicion of ischemic causes are suspected. For the glycemic control, the levels are usually are normal, 140 to 180 milligram per deciliter. We have to maintain the multi-organ involvement. The RRT should be initiated if needed. Infection prevention is mandated, and infection support is mandated. And the 5H and 5Ts of the cardiac arrest ACLS program need to be rolled out timely. The guidelines and recommendations are such that AHA 2020 guidelines recommend TTM for comatose adult patients. ACLS 2021 update confirms TTM for comatose survivors, emphasizes continuous core temperature monitoring and strong fever presentation even if cooling or not applied. The ERC 2021 guidelines advocate multimodal prognostication 72 hours post-ROSC, continuous EEG monitoring and coronary angiography suspected ACS. The recent updates of 2023 highlight mandates findings from TTM2 trial because no mortality difference was found in hypothermic patients at 33 degrees centigrade and versus normothermic patients with fever prevention. Thus, normothermia is now acceptable in some cases. Predictors of prognosis. Poor prognosis include the absent brainstem reflexes or patient in status epilepticus, patient in myoclonus, and unfavorable EEG or imaging findings after 72 hours of optimal care. This was an algorithm that has been published in the 2020 guidelines in adult post-cardiac arrest care algorithm. So this is another topic like prognostication of cardiac arrest has come in the exams. The principles of prognostication of cardiac arrest are prognostication should be delayed more than 72 hours after dose and after rewarming if TTM is applied. It must be multimodal because it involves clinical exam plus electrophysiology like EEG monitorings and others, and the biomarkers and the imaging. And avoid confounders like the residual sedation, hypothermia, and metabolic disturbances. Poor prognostic indicators should be seen after actually the prognostication should be done after 72 hours, and the poor prognostic indicators which suggest the poor prognosis of the patients in absence of confounders are bilateral absent pupillary light reflex, bilateral absent corneal reflex, and status myoclonus within 72 hours of RSC. EEG findings like highly malignant patterns like suppressed background or the burst separation pattern or status epilepticus or plates pattern with the poor outcomes, continuous EEG recommendation is recommended in comatose patient. Coming to somatosensory evok potentials, bilateral absent in 20 responses at more than 24 hours, highly specific of poor prognosis and poor outcome. For the biomarkers, neurospecific anolis, it is persistently high or rising levels at 40 to 72 hours, suggests a poor neurological outcome. Other markers are being studied in research are like the tau protein and the glial fibrillary acidic protein. For the neuroimaging and the CT-MRI findings, suggestive of poor outcomes like diffuse cerebral edema with loss of gray-white matter differentiation and diffuse hypoxic ischemic injury or MRI. This we have already discussed, I guess. Yeah. So prognostication as per AHA 2020 guidelines only after 72 hours. The ILCO 2022 emphasizes multimodality, delayed timing, and standardized protocols. No single test is sufficient, and we have to usually combine more than 2 predictors for reliable prognostication. This is the algorithm and the recommended approaches for neuroprognostication. This is published in the ACLS multiple neuroprognostication guidelines. You can go through it. Next.
So in this poor prognostication, you might get short notes on only on N20 and SSEP also. So prepare for that too.
Resuscitation, we will now jump to here's some questions that has come previously with relation to procedures. We
Sir,
will start with
a little request, full screen.
yes, ma'am.
Thank you so much.
Start with forgiveness tracheostomy. So we can divide our answers in this heading, subheadings: definition, applied anatomy, indications, contraindications, techniques, equipments, procedure, advantages versus surgical, complications, and post-procedure care. So definition is like straight cut, bedside procedure to create an artificial airway by inserting a tracheostomy tube into the trachea through a forgiveness approach. It is a minimally invasive and it is always an elective procedure. The anatomy of the trachea is that it extends from the cricoid to the rhino at the level of T4 to T5. Length is around 10 to 12 centimeters. Diameter is around 15 to 20 millimeters, composed of 16 to 20 C-shaped cartilaginous rings with posterior membranous wall, which is also known as the trachealis muscle embedded in it. Site usually between second and third or third and fourth tracheal rings. We should take the puncture. The surface anatomy are anteriorly it is covered by skin, that is not cervical fossa, thyroidisthmus, and anterior jugular veins. And posteriorly it is bounded by esophagus. Laterally it is the carotid sheath, and inferiorly it is the brachiocephalic or the innominate artery. We have to be cautious while for puncturing or doing a percutaneous tracheostomy because this innominate artery are notorious to cause torrential bleed. Coming to the arterial supply, the upper trachea is usually supplied by the inferior thyroid artery, which is a branch of thyrocervical tract. Lower trachea is supplied by the bronchial arteries. Additional contributions can be seen in some patients with the superior thyroid artery. And the clinical relevance is this high riding that we were talking about. The high riding innominate artery because anterior trachea, risk of fatal hemorrhage puncture. Venous drainage is done by the anterior jugular veins and the inferior which usually drain to the brachiocephalic veins and then into the superior vena cava. Indications of percutaneous tracheostomy: well, prolonged mechanical ventilation more than 7 to 10 days anticipated. Failure to wean patients, need for a airway toileting or because of copious secretions. Patients with upper airway obstruction or airway protection, and neuro patients. The contraindications are absolute contraindications, usually local infection at site, uncorrectable coagulopathy, distorted anatomy. Well, there are no absolute contraindications for such procedures if it needs to be done. The relative contraindications are high PEEP or FiO2, obesity, pediatric patients, cervical spine instability, severe hypoxemia require high PEEP or FiO2. Techniques, usually these are the techniques that has been used. Ciaglia or the multiple dilated technique, Ciaglia blue rhino technique, which is the used, Briggs dilating forceps, percute twist, and pancreatic transpharyngeal techniques. The equipment usually required the tracheostomy kit or the tracheostomy set, which usually contains the needle, the guidewire dilator, and the cup tracheostomy tube, the bronchoscope for guidance to pull out the tube and to see the proper localization of the puncture. It is usually considered as a gold standard and standard monitoring devices. For the consent, for the procedure, we have to start with consent, then preparation, then positioning, procedure. The patient should be supine, neck extended. Landmarking should be done under ultrasound or bronchoscopy. Needle puncture usually into the trachea between the second or third rings. Guidewire insertion and serial or single dilatation. Usually we do 2 or 3 dilatation of the tract using different corkscrew methods. The insertion of the tracheostomy tube over the guidewire and confirmation by capnography, auscultation, bronchoscopy. Post-procedure care is mandated with daily stomach care, securing the tube, adequate humidification, and pressure monitoring. Advantages are avoidance of transfer of a critically ill bedside procedure, It's avoidance of transfer. Less bleeding due to a tight stoma or small incision with a snugly fitting tube. Lower rates of wound infection. It is cost effective and patients are usually comfortable, and the speech and mobility and swallowing therapies can be ensured. Also, proper oral care and hygiene can be given to the patient. Complications are can be divided into immediate, early, and late. For the immediate complications, usually bleeding, pneumothorax, and posterior puncture are seen. In early complications, usually the malposition, blockage, subcutaneous emphysema, or any late bleed, any venous bleed. For the late complications, tracheal stenosis, tracheoesophageal fistula, ventilation tissue, and tracheomalacia. Decannulation criteria are usually the standard decannulation criteria that, but there are some nuances. The decannulation criteria where the mechanical ventilation is no longer needed, the patient can produce and have effective and adequate cough reflexes. There is minimal secretions and there is no evidence of any upper airway obstruction. Trials with respect to tracheostomy, we have the TRACMAN trial and the SET.2 trial where they talk about the timing, where it has been shown that early tracheostomy does not improve long-term functional outcome and does not confer survival or stay benefit. And for tracheostomy trial, which usually suggests the technique, where they have seen that ultrasound-guided percutaneous tracheostomy is safe to use and over laminal-guided or bronchoscopic-guided percutaneous tracheostomy. This ends up your answer for this question. Diagnostic thing. This question has come for it's related thromboelastography. So coming to the definition of it, it is elastic hemostatic acid that provides a comprehensive assessment of the coagulation process in whole blood. Unlike conventional coagulation tests like APTT, PT, and INR, it evaluates the initiation, formation, strength, and breakdown of the clot in real time and reflects the interaction of the platelets with the immunity system. The principle is that the sample of whole blood is placed in a heated cup, maintained at 37 degrees centigrade, and either the cup or the pin oscillates slightly. As the clot forms, the resistance to the movement is detected and translated into a graphical trace. This trace represents the dynamics of the clot formation, the initiation, the propagation, and the stabilization, and eventually the lysis of the plate. This whole process is being seen in thromboelastography. What are the key parameters we see in thromboelastography? The R time, which is the time to initial fibrin formation, the K time, which is the time to reach the fixed clot strength, the alpha angle, which reflects the rate of clot strengthening, the maximum amplitude of the maximum clot strength, the lysis 30 or the percentage of the clot lysis seen at 30 minutes after the maximum amplitude, and the coagulation index. So this is the pictorial diagram. You can draw it, fetch more marks. So the indications, come to the indications, in massive transfusion protocols in cardiac surgery patients, in liver transplantation patients. Well, the take was first initially mandated for liver transplant patients, but now it has been extrapolated. The data has been extrapolated and it can be used in many other scenarios. In obstetric hemorrhage, in monitoring anticoagulation reversal therapy also, and in critical illness and sepsis coagulopathy, we can use take to monitor our transfusion protocols. Clinical applications, it provides a rapid bedside guidance for transfusion therapy and allows differentiation between coagulation factor deficiency, fibrinogen deficiency, platelet dysfunction, and hyperfibrinogen lysis. In this way, by doing this, we minimize the unnecessary transfusions and optimize the patient outcomes. When we talk about recommendation and guidelines, the European Society of Anesthesiology and Intensive Care and the ASA recommend the use of TEG or ROTEM in managing massive bleeding during trauma, liver transplant surgery. Goal-directed transfusion strategies can be done by avoiding the complications, and it should complement, not completely replace, conventional coagulation steps. Test interpretation should be done by trained personnel due to variability and influencing factors. How ROTEM is different from TEG? Well, the TEG uses a pin suspended in a blood cup oscillation, whereas ROTEM uses an oscillating cup with optical detection. The reagents, the ROTEM use pre-packaged specific activators, making it more standardized, while TEG often requires manual reagent addition. ROTEM is considered more user-friendly and automated, while TEG is operator-dependent. And the nomenclatures as we discussed, take the parameters of the R time, the K time, the alpha angle, MA amplitude, and the Lysis 30, where routine parameters are CT, CFT, alpha, MCF, and the LI 30. The clinical utilities are both provide similar clinical information, but the routine may have faster and more reproducible results in critical care settings. Both are recommended equivalent measured trauma, transplants, and cardiac surgery guidelines. The limitations are TEG requires technical expertise and may be influenced by hypothermia, anemia, platelet count, or hemodilation, and there is a lack of standardization. So we can write the conclusion like it's an invaluable tool in critical care and perioperative medicine, but it provides a global picture of hemostasis and helps in personalized transfusion and anticoagulation strategies. Despite limitations, its use is strongly supported in trauma and cardiac surgery and liver transplantation by multiple guidelines. So this is the pictorial diagram where we can see the difference between the
Get a full
parameters.
screen, Dr. Abhinav, so that
Sorry,
it
ma'am.
is,
Yeah, sure. So these are the parameters and the normal ranges that, as I mentioned over here, the difference in the TEG and the ROTEM, and the parameters that we see are the same, but ROTEM is more reproducible and is more easy to do. Next. So this is another topic that we would like to mention is the intercostal water seal drainage. So it was a long question of around 10 marks, I guess, in 2022 paper of DNB critical care exam. So we can usually divide the answer in subheadings. Like definition, start with the definition. It's a water seal drainage system. It is a closed drainage system and is used to allow air and fluid to escape from the pleural space with each exhalation and to prevent the return flow with each inhalation. Indications, we can enlist the indications and we can enlist the relative contraindications. We can read it out. The indications are the traumatic pneumothorax, pneumothorax, spontaneous pneumothorax, iatrogenic pneumothorax. In cases of malignant pleural effusions, in empyema, it's empyema, in malignant pleural effusions, large pleural effusions, and the relative contraindications usually are pleural adhesions, the uncorrected coagulopathies, and in some cases of diaphragmatic hernia. Coming to the applied anatomy, you can draw this diagram where we can see the safe window of safety, triangle of safety, through which the ICD should be inserted with minimal complications. The ATLS guidelines has now changed the second intercostal space for the pneumothorax to fifth intercostal space. So it is the fifth intercostal space, be it a hemothorax or a pneumothorax or a large pleural effusion. The insertion site is anterior to the mid-axillary line, and it is usually at the superior aspect of the rib, that is the upper border of the lower rib. Because we need to avoid the intercostal vessels. The layers reached are skin, subcutaneous tissue, intercostal muscles, and parietal pleura. And intercostal neurovascular bundle, as we have talked, it lies in the inferior aspect of the rib. So you should avoid piercing through that lower border. We should usually use the upper border. Principles: gravity enhances flow from high to low flow. Chest drain is placed below the patient's weight. Underwater seal, it is a barrier to prevent the backflow to the pleural space. And the rod depth, the depth of the rod usually determines the negative pressure. So if the rod depth is 2 centimeter below the water, the pressure is around -2 centimeter. Air bubbles is released through the rod. Air vent is used to allow drained air to escape to prevent the pressure buildup. The suction is required when gravity drainage is not. Patient's respiration and cough are too weak, and the air is fast into the pleural space. We should need to remove the removal from pleural space. Suction is required for that time also. What is the purpose? The purpose is to permit drainage of air and fluid from the pleural cavity, to establish normal negative pressure in the pleural cavity for lung expansion, to equalize the pressure on both sides, and to provide continuous suction in cases of tension pneumothorax and in cases of bronchopleural fistula. So some of the systems that we use is most commonly used is the one bottle drainage system. You can see the diagram. You can draw the diagram in your paper. Coming to the advantages of it, it is easy to transport. It's ideal for uncomplicated pneumothorax, and it's simple and cheap. But the disadvantages are, as more fluid drains, the fluid level rises. Tube tip becomes deeper, as we have said that the length of the tube tip till the water determines the negative pressure that the patient needs to generate. So the higher pressure might be needed to generate for the patient for further drainage. So it becomes exhausting for the patient. Risk of fluid reflux into the pleural cavity, the bottle is placed above the chest, and drainage is usually gravity dependent. This is the two bottle drainage system, where the one bottle drainage system is intact, but we use a second bottle drainage system to apply suction of around -15 to -20 centimeter of water. Advantages are it is ideal for pleural effusion, pneumothorax, and pneumothorax, fixed underwater seal levels. The pleural fluid and the water seal are separate. And the disadvantages are it is gravity dependent, and in large air leaks, gravity alone may not be sufficient. So there we see the three bottle drainage system, where one is for the drain for the collection, and the other is for the excess air. So the advantages are the adjustable pressure of the suction. The pressure can be adjusted by manipulating the depth of the vein tube in the actually, uh, where it is effective for both pneumothorax and pleural fluid, and there is no chance of the fluid going back up to the tubing. The disadvantages are the continuous bubbling can happen, the suction can increase the air leak, and it can precipitate or it can uh, present the patient to a bronchopleural fistula. This is the diagram of the Pleurovac closed system, which are being commonly used by many pulmonologists in many critical care ICUs also, where it's a single chamber system where in a single chamber you have all the three chambers. You can draw it out. The drainage system is disposable, molded plastic unit with three chambers, duplicating the classic three bottle system. Its advantages are it is an underwater seal. It has a transparent collection chamber, so you can see positive pressure release valve is there to remove the excess pressure when the patient is coughing sometimes. So the excess pressure can be released through a pressure release valve. There is the float valve, and the float valve is usually used when we make the patient for any positioning or any physiotherapy sessions, or when the patient tries to lie laterally. So the float valve actually is like a barrier to the exchange of the fluid from one chamber to the other chamber. There is also a chamber for the dry suction control. We can attach the suction monitor, or the suction machine. There is a air leak monitor, and there is a retractable stand and bedside hanging arms to prevent the accidental spills. So steps of ICD insertion. Step one is patient positioning. Step two is checklist. We should ensure the materials are ready, assistant is available. Step three is skin prep and local anesthesia. Incision is step four and entry. Step five is the tube insertion and advance the ICD and connect it into the underwater seal drainage system. Step six is position confirmation by using X-ray, or the most definitive sign is to see the swing or the bubbling. Step seven is documentation, and step eight is ICD care. The drain should be below the chest. Sterile water seal. Cough therapy and the physiotherapy should be regularly done, and the monitoring of the site and the saturation should be always done. We should always ensure that when a patient is having such sort of things, the things should never be clamped, at least in the initial phase. Criteria for removal is the absence of air leak. The drain fluid is less than 50 to 75 ml per day, and chest X-ray should reveal the re-expansion of lungs, and it is well continued. So this was the end of this thing, the intercostal water seal drainage. Now we move on to some recent topics, some diagnostic topic like the microcirculation in the evaluation of septic shock. A short introduction is the shock in the need of resuscitation is a condition in which oxygen delivery to cells is insufficient to sustain cellular activity and support the organ function. All the parameters that we use are used as macrocirculatory parameters. Like the whole goal of the hemodynamic resuscitation is to meet the oxygen and the metabolic demands of the various organs. But we never know the microcirculation and the tissue oxygenation optimization are achieved after the macrovascular optimization. The challenge for the future is to have a non-invasive, easy-to-use equipment that allows reliable assessment and immediate quantitative analysis of the microcirculation at the bedside. So coming to the anatomy of the microcirculatory system, the smallest unit is defined as a microcirculation. It is a vast network of capillaries and is smaller than 100 microns in diameter. The arterioles, venules, and the capillaries all together form this network, which should be regarded as in different entity or organ. Under non-pathological conditions, microcirculation holds approximately 10% of the circulating volume. And the arterioles and venules, which are less than 20 microns, and the capillaries which are less than 10 microns, are the main site of the oxygen transfer to the tissues. The RBC is approximately 8 microns in diameter, and these cells need to deform to enter the capillaries to and form a single-like formation. So, endothelial cell lining covers the entire lumen of the microcirculation. This integrity of the endothelial cell lining actually constitutes the glycocalyx, where the glycocalyx is composed of three things: the proteoglycans, the glycosaminoglycans, and the glycoproteins. Uh, so this is the basic anatomy of the microcirculation that we were talking about. Now coming to the pathophysiology, what happens exactly? It's the in this microcirculatory disturbance in septic shock. It is usually the loss of hemodynamic coherence, the generation of the reactive nitroso-active and the oxidative species, which results in the loss of vascular regulation. The endothelial glycocalyx is disrupted. There is compromised endothelial cell function, and there is compromised barrier function, which results in tissue hypoxemia. So this loss of hemodynamic coherence is usually being done by the pro-inflammatory cytokines, by the DAMs and the PAMs also. And the interventions which are aimed at improving the shock, like we do fluid administration, we give antibiotics, we give catecholamines, they may in themselves cause injury to the glycocalyx and the microcirculation. The endpoint is that there is dysfunction in the microvascular perfusion, and this leads to organ failure. Thus, assessment of the microcirculation is very much crucial. So a bit about hemodynamic incoherence. We were talking about hemodynamic incoherence. So what is this hemodynamic coherence? It is a condition in which the resuscitation procedures aimed at the correction of the systemic hemodynamic variables are effective in correcting the regional and the microcirculatory perfusion, and this leads to good oxygen delivery to the parenchymal cells. Studies have consistently shown that the persistence of the microcirculatory alterations with the loss of coherence between the macro and the microcirculations is predictive of organ failure. So, this impaired microcirculation, as we discussed, can happen due to multiple factors like alteration in blood viscosity, endothelial dysfunction, glycocalyx degradation, and microthrombi or microaggregates. These four types of microcirculation alterations underline the loss of hemodynamic coherence. The first one is type 1 heterogeneity in microcirculatory perfusion with obstructed capillaries next to capillaries with the flowing RBCs. I'll show you a diagram. Type 2 is hemodilution, in which there is dilution of the blood causes a loss of RBC-filled capillaries. Type 3 is vasoconstriction tamponade, where vasoconstriction of the arterial vessels results in microcirculatory ischemia. And type 4 is the tissue edema, causing capillary leak and results in increased diffusion distances between the RBCs and the tissue cells. I think I lost it. Why is the study of this microcirculation essential to help guide therapeutic strategies in ICU? Oxygen transport to the cells occurs via the RBCs, and mainly it is done by convection and diffusion. There is a complex mathematical formulas for this to show the flow of oxygen carrying red blood cells of RBC flow rate by using convection and the diffusion. So, whatever we assess are the macrocirculatory parameters. Now we will just discuss about the microcirculatory parameters that we see in our day-to-day life practice in the ICU, and what others can be are in studies. What we commonly see are the capillary refill time. It has been popularized much more after the Andromeda shock trial. The technique is that the pressure application to the fingertip for at least 10 seconds until the skin showed whitening, and the time until the return of the baseline coloration is usually measured with a chronometer. The normal is around less than 3 seconds. It is simple and quick, but it is a visual assessment, is a subjective modality, and it is important to obtain objective and reliable measures of capillary refill time. We also do the VPC to PCO2 gap, where we see the difference between the carbon dioxide, the PCO2 values in the VBG and the ABG, and we see the gap. And the strength is a reliable indicator of impaired tissue perfusion, but the challenge is that to demonstrate that the normalization of a VPC-CO2 difference has an impact on the outcome of patients in shock, the trials are lacking actually. The modeling score we commonly use, but it's a subjective scoring, and it usually shows how much the grave shock is. There are other parameters like the plethysmography, where we use the pulse co-oximetry, and it continuously provides a non-invasive measure of peripheral perfusion called the perfusion index. It is actually the ratio of the pulsatile and the non-pulsatile light absorbance of the rear and infrared light passing through the tissue. The strengths are it can be used to assess the fluid responsiveness, also allows for continuous non-invasive monitoring of the hemoglobin concentration and oxygen reserve also. The challenges are it needs to evaluate accuracy and precision. These are the newer advances. The handheld vital microscope, it uses the epi illumination by the green LEDs to illuminate and magnifying lenses. So it uses beams, the light emitting diodes, and at the tip of a light guide to observe the microcirculation of a region of interest. These are used for direct observation of the flowing blood cells in areas where the capillaries are very much thin, like the buccal mucosa or the sublingual mucosa, and these are quantified as microcirculatory flow index, percentage of perfused vessels, and total vessel density. These three generations of handheld vital microscopes have been developed, like the orthogonal polarization spectral OPS, the SDF, the side stream dark field, which are being frequently used and in research, of course, and in incident dark field imaging. And the IDF is actually superior. Sublingual macrocirculation is the most frequently studied macrocirculation at the bedside. The challenges are there is movement artifacts, the pressure artifacts, and it requires patient cooperation also. But the large database validation of automated quantification of the microvessel density and the red vessel viscosity and the velocity are the next steps towards real-time clinical application at the bedside. But it has not been standardized actually, so not been used that much. The other techniques are the contrast enhanced USG, which uses gas macrobubbles, and this is surrounded by stabilizing envelope, which is usually a phospholipid or protein envelope of a size like that of the RBC, and it allows them to cross the pulmonary capillary bed and reach the capillaries of the different organs. The size is large enough and they do not cross the endothelium, making them true intravascular agents. It is a quantitative analysis. These are performed using a different specific software, and usually we see the region of interest. The software generates a time intensity curve, and then it calculates the amplitude and the time parameters, which are proportional to the blood volume and the microvascular blood flow. The strengths are the analysis of the microcirculation of the regional perfusion of deep organs can be done at the patient's bedside only. But as the challenges are, it is still in the research phase and the validation are still dicey. Laser Doppler flowmetry, we see the shift in the light wavelength, that is, which is proportional to the red blood cell velocity in the studied area. It is a non-invasive measurement. The microcirculatory reactivity is decreased in patients with circulatory shock, and it has some prognostic value. It cannot be used as a diagnostic value. That's what was being mentioned in the research paper. Skin laser Doppler could be coupled with local thermal challenge may provide a measure of microcirculatory reactivity. The challenges are impact of monitoring on outcome in critically ill patients still in research phase. MRI has been used as a microcirculatory parameter to evaluate the microcirculation in septic shock. The phase contrast MRI, the arterial skin leveling, the diffusion weighted MRI, and the blood oxygen level dependent MRI. You can just mention the names and some strengths and challenges. The challenges it cannot be used to dynamically monitor the microcirculation in real time at the patient's bedside, and it also needs radiological expertise. Near infrared spectroscopy, we do it sometimes. The technique is the tissue oxygen saturation, which is the ratio of the oxygenated to the total tissue hemoglobin concentration. It has found usage in the monitoring of cerebral and the muscle oxygenation in cardiac surgery and critically ill patients. It is non-invasive and is easy to use. But the impact of the other molecules like the myoglobin, the skin color, and the pigmentation and the scatter of the light of the environment, we do not know about those impacts. The deeper tissues such as the muscles bounce back most of the signals in, so the signals can be misleading. Tissue oxygenation can be overestimated if a tissue mass exists in the region of its interest, and the values will be erroneous, and it is not standardized. The evidence, coming to the evidence to adopt this microcirculation techniques, as we discussed, the Andromeda shock trial suggested the capillary refill time, which is a microcirculation guided strategy, can be used as a surrogate parameter where they have compared CRT with lactate. Monitoring the sublingual microcirculation using handheld vital microscope may help discriminate patients from specific therapy in patients with septic shock or a perioperative shock or a hypovolemic shock. As advanced sensors and HBM modalities develop and are placed in the patients, it may envision the creation of an good ICU patient with continuous in vivo monitoring. Future therapies targeting microcirculation are the manipulation of the nitric oxide pathway, manipulation of the arachidonic acid pathway, manipulation of pro-adhesive and pro-coagulant pathway, the manipulation of the oxidative pathways using albumin as an interesting therapeutic option. In the face of persistent microvascular alterations, clinicians should assess the microvascular response to a fluid challenge. And then in the absence of a response, test the administration and increase of vasopressin doses. The availability of capillary hemoglobin to refine the administration of RBCC is still being studied. And in the absence of a response to previous therapeutic strategies, the administration of microvascular vasodilators may be considered in the future. Patrick, I think I missed the diagram actually. Next. There is another diagnostic question. Question on diagnosis that has come in previous year's question paper. Focus in ventilator-induced diaphragm dysfunction. We'll discuss something of it as an answer. So definition is ventilator-induced diaphragm dysfunction is a loss of diaphragmatic force generating capacity due to mechanical ventilation independent of the underlying disease. The pathophysiologies are the control modes. It usually causes complete unloading and it leads to disease atrophy within 18 to 48 hours. Excessive support in the pressure support ventilation causes reduced contractile activity of the diaphragmatic muscles, leads to atrophy. High respiratory drive patients and patients who are under assisted, they usually lead to overload and fatigue injury. The mechanisms usually are oxidative stress, the mitochondrial dysfunction, and the proteolysis. The clinical impact, prolonged weaning, high extubation failures, ICU mobility, increased ICU mobility, and increased ICU mortality. What are the preventive strategies? Usually we can use early shift to partial support or spontaneous modes like support ventilation or NAVA assist devices or proportional assist ventilation. Avoid both excessive unloading and overloading. Inspiratory muscle training, early mobilization, concept of diaphragm protective ventilation. So, role of focus in diagnosis of ventilator-induced diaphragm dysfunction and weaning. The advantages are it is bedside, non-invasive, and repeatable and dynamic. The key parameters needs to be mentioned, which are diaphragmatic excursion. We use the M mode in the subcostal region in the mid-clavicular or between the mid-clavicular and the anterior axillary line. The usually less than 10 to 11 millimeters is suggestive of dysfunction. The diaphragmatic thickness at the zone of apposition using the linear probe, where we place the linear probe at the 8th to 10th intercostal space in the in the anterior axillary to the mid axillary, between the anterior and the mid axillary line. Usually less than 2 millimeters is suggestive of atrophy. And using the diaphragmatic thickness, we can usually measure the diaphragmatic thickness fraction. It's a formula, and usually less than 20 to 30% is usually suggestive of dysfunction. The clinical uses are, as you have mentioned, it can identify VIDD as a cause of weaning failure versus cardiac or pulmonary cause. So this diagram you can put if at all it's necessary, the USG findings, where the guidelines and the recommendations regarding ventilator-induced diaphragm dysfunction and the use of focus are like the ATS and the ERS weaning guidelines as of 2017 shows that ultrasound may be used as an adjunct to clinical respiratory mechanics during weaning. ESICM expert consensus recommends standardization of diaphragm ultrasound techniques. It supports its use in monitoring diaphragm activity during mechanical ventilation. The recent reviews suggest incorporating diaphragm ultrasound into weaning protocols, especially in patients at high risk of prolonged ventilation. Concept of diaphragm protective ventilation is emerging but not yet universally guideline mandated. The limitations are evidence is still lacking. The cutoffs are variable across studies. It has not been standardized. It is also subjective. The operator training and standardization are critical for reliable results. Focus should be used as an adjunct, but not a sole determinant for winning variance.
Dr. Abhinav, I have mailed you one more slide now for diastolic dysfunction.
Um, Audible, ma'am?
Avrav, you have to do full screen.
Yes, am I audible, ma'am? Which might be which you might expect in our upcoming exams, which is the echocardiometric applications for diastolic dysfunction at the bedside. Uh, so, I think I'm audible, ma'am.
Yes.
Relaxation of the cardiac muscle fibers is an active process that transfers the cytoplasmic calcium back to the cytoplasmic reticulum, and this reactivates the inhibitory effect of the troponin tropomyosin complex and allowing the dissociation of the actin and myosin filaments. The effect is drop in LV pressure rate, which decreases in the first phase directly reflects the muscle fiber relaxation. This velocity can be measured with invasive techniques and is often defined as the maximum descent velocity, or the dp by dt, or the time constant of the isovolumetric relaxation. The phases are the this is the phases of the diastolic function. We can see it like that. This is the first phase is the isovolumetric relaxation. The second is the rapid filling. The third is the slow filling, and the fourth is the atrial contraction or the atrial kick. So this was the Weger's diagram that we had studied earlier, where we can see the phases of systole and diastole. The diastole is a bigger one. There's a of the two of the between the systole and the diastole, so it requires more time for the diastole to happen, and it has four phases: isovolume relaxation, rapid inflow, the diastasis or the slow filling, and the atrial systole. It begins during late systole. It is energy dependent and does not control ventricular filling. The rapid filling is usually provides most, that is 65 to 75% of the volume of end diastole. The slow filling provides only 5%, and the remaining phase is usually contributed by the atrial peak, which is around 15 to 20%. Coming to the small like summary of the pathophysiology of the diastolic dysfunction, where it is actually the abnormal LV mechanical and functional properties. There is slow or delayed relaxation, there is decreased LV distensibility, and there is impaired LV filling. The consequences are the LV filling becomes pressure dependent. Either LA pressure rises to maintain the stroke volume, and we see pulmonary venous hypertension and congestion, or the filling cannot happen actually. It is incomplete and it leads to reduced stroke volume and exercise intolerance. If the RA is followed, the LA pressure, when the LA pressure stays normal, there is incomplete LV filling and leads to reduced stroke volume. And if there is increase in LA pressure, it helps in maintaining the stroke volume, but it usually causes the back pressure changes and leading to pulmonary venous hypertension and pulmonary congestion. Progression to it, when it is early, the abnormalities are seen only with exercise or stress. If it is advanced, the symptoms are seen at rest also. So this is the algorithm of the pathophysiology. You can put in writing. In spite of writing line by line, you can just put it in writing as a flowchart. So the thing is that abnormal early filling, only mild problem we see. Diastolic abnormalities are subclinical and normal exercise tolerance is being maintained. In cases of elevated LV and pulmonary pressures, there is dyspnea on exertions, and it usually leads to diastolic dysfunction. And the patients are usually symptomatic during stress time. In cases of diastolic heart failure, there is usually atrial enlargement, the atrial fibrillation also ensures. There is reduced cardiac output, and there is signs of cardiac congestive heart failure. What are the stages of diastolic dysfunction? It is usually normal. The stage one is normal, stage two is impaired LV relaxation, as we all know. Three is pseudonormal, or the abdominal relaxation is just increased LV and diastolic pressure, and the fourth one is restricted LV filling or advanced reduction in compliance. The These are the invasive assessment for LV diastolic dysfunction and half cough. These are usually being done by using the high fidelity catheters in the left ventricle or the pulmonary artery catheter, but these are not being used much this moment. We use the pulmonary artery catheter, but for the LV chamber stiffness contains, the high fidelity LV catheters are not in use anymore. But previously they used to assess the LV diastolic dysfunction using this invasive assessment. The parameters are time constant of LV relaxation, the LV chamber stiffness constant, rest mean pulmonary capillary release pressure, and rest LV and diastolic pressure. So we have this definition like the I can write it because these are has been mentioned by the PA catheters and the cardiac output catheters. The studies have been found that Doppler measurements that correlate better with the mean LAP or the PCWP include the mitral E velocity, EA ratio, and the E by E prime ratio. The echocardiography measurements that correlate better with the LV and diastolic pressure include the mitral A velocity, pulmonary vein atrial reversal velocity, and the time difference between atrial reversal duration and that of the mitral A duration, and LA pump strain. LV indices actually tell us how the LV is behaving in terms of relaxation or stiffness, but the LV indices tell us how the atrium and the pulmonary circulation is affected. So, when it comes to grading the diastolic dysfunction with respect to echocardiographic indices, we are talking about the abnormal LV relaxation without elevated LAP is actually grade 1, where it is just impaired relaxation. When coming to pseudonormal, it is abnormal LV relaxation with elevated left atrial pressure. And when there is severe diastolic dysfunction with very high LAP, it is actually the grade 3 diastolic dysfunction or the restrictive filling. Uh, so, uh, so while performing an echocardiographic indices, echocardiographic evaluation of the diastolic function, we usually some modes. We usually use a pulse Doppler wave velocity, and we usually put the Doppler waves into the mitral valve leaflets and the tip, and we see that these waveforms, this kind of waveforms, which are the E wave, and there is the A wave. From the peak E wave, we see the peak early diastolic velocity after the ECG T wave, and the normal is around 50 to 100 centimeter per second. And from the A wave, which is the peak A wave, it is the peak late diastolic velocity or the actual peak velocity. After the P wave, it usually comes after the ECG P wave, which it is usually around 20 to 40 centimeter per second. These numbers are important because this is the normal parameters. These are normal numbers which you find in normal diastolic function patients. Coming to the deceleration time, it is the time interval from the peak velocity along the deceleration slope to the zero baseline, which is around 160 to 40 meter per second. And the E by A ratio later. Uh, so the mitral E wave velocity reflects the LA to LV pressure gradient during early diastole, and it is affected by changes in the rate of LV relaxation and LAP. The mitral A wave velocity, it is a LA to LV pressure gradient which is seen during late diastole. It is maintained by the atrial contraction. The mitral deceleration time, it is influenced by the rate of decline in the LA-LV pressure gradient after the mitral valve opening, and therefore LV relaxation and LV stiffness. And the mitral E by A ratio is used to identify the filling patterns like normal, impaired relaxation, pseudonormal, and restrictive filling. However, you have seen that I have mentioned the disadvantages. These parameters are only valid when the patient has got a sinus rhythm, when there is no valve abnormalities, and all such things. Coming to the mitral valve inflow patterns, as we were seeing in the other slide, where we are seeing the EA ratio. So the mitral valve inflow patterns can have these three sorts of ratios, where if the EA ratio is less than 0.8, it is likely normal. Where the EA ratio is more than 2, the LAP is likely high, but the E by A ratio of around 0.8 to 2 is kind of indeterminate. The patient can have a pseudonormal or can have a grade 3 diastolic dysfunction. So how to go with that? So then there are other parameters also we will see, like the interventricular relaxation time. It is measured at the time interval between the aortic valve closure and the mitral valve opening, where what we do is like we put a continuous wave Doppler and we put it and we actually take out a 5-chamber view and we put the continuous wave Doppler just in between the aortic valve opening and the mitral valve opening in between, and usually we get the interventricular relaxation time. The normal in IVRT is around 50 to 100 meter per second. It reflects the time interval of the aortic valve closure and the mitral valve opening, as I mentioned, and it is the crossover between the LA and the LV pressures. So the duration is directly related to the LV relaxation and inversely related to the left atrial pressure. That is, it is prolonged with impaired LV relaxation and normal LV filling pressure, shortened with increased LAP. If you can find out this sort of echocardiographic image, we can usually say whether the patient has got a grade 2 or a grade 3 diastolic dysfunction. The other parameters where we can use to determine whether the patient has got a pseudonormal or a abnormal diastolic dysfunction is the most important, which is the tissue Doppler at the mitral annulus, where we usually use the tissue Doppler, and we usually use at the septal annulus, and again we use at the lateral annulus of the mitral valve, where we see the waveform. There is a E prime velocity, which is the early diastolic velocity of the mitral annulus. After the ECG T wave, the normal is around less than 7 of the septal annulus, and the lateral annulus is around less than 10. A prime velocity, it is the peak leg diastolic velocity or the atrial contraction after the ECG P wave. The MV E by E prime ratio is to MV peak E wave divided by the tissue Doppler E prime velocity. So, uh,
Think some problem with uploading the slide?
there is some problem with uploading, I guess.
Yeah. Oh no. After this also, I think 2, 3 slides were there.
Yes, just 2, 3 slides were there, no?
Hmm. Can you share the original slide then for this? Hello. ठीक है, बायोमार्कर्स का भी I have sent you, and इसका ना फिर ओरिजिनल स्लाइड में करके ना ओके ओके ठीक है ठीक है ठीक है हाँ. So Dr. Abhinav had to leave for an emergency. So the last topic, I'll finish this the missing slide, but the last topic I want to cover is the biomarkers used in critically ill patients. Just give me 1 minute to open the slide. Is it visible?
Not yet, ma'am.
No, not yet.
Yeah.
Okay. Is it visible now?
Yes, ma'am.
Okay.
You just have to do full screen. Perfect.
Yeah, you can start.
As usual, my laptop is giving me the problem. Yeah. Okay. Organism predict clinical course and prognosis, guide the therapeutic decisions. So biomarkers in sepsis that we include antibiotic-related harms without increasing mortality. Second is CRP. CRP is a non-specific marker of inflammation and is widely used for monitoring trends. It is less specific than PCT for bacterial infection, but remains clinically useful when followed over time. No major trial demonstrates mortality benefit from CRP guidance, but it is incorporated in many ICU practices. Definitely, it is cost effective also from with respect to PCT. And lactate, that is a serial measurement that is very important as per the surviving sepsis guideline also. Lactate is a well-established marker for risk stratification and for guiding resuscitation in sepsis and shock. The Jones et al. In JAMA 2010 trial showed that lactate clearance guided resuscitation was non-inferior to SCVO2-based resuscitation. So early lactate clearance is strongly associated with improved survival. So that's how they switched from SCVO2 to lactate, because SCVO2 always needs a central line, and that is more invasive. So the guidelines switched from SCVO2 monitoring to lactate monitoring. Now, newer diagnostic markers in sepsis, these are the evolution, that is pre-sepsin. Soluble fragment of CD14 released after bacterial phagocytosis rises earlier than PCT, potentially useful in early diagnosis. Several meta-analyses suggest superiority over PCT, and prognostic role remains debatable, but definitely as it is evolving, not available worldwide. Second is soluble TREM1, that is triggering receptor expressed on myeloid cell 1, derived from neutrophils, monocytes, amplifies inflammatory response. Moderate diagnostic accuracy, that is sensitivity, is 79%, and specificity is around 80%, so definitely not very good. Body fluids level may help distinguish infectious from non-infectious inflammations. CD64 index, that is FC receptor upregulated on neutrophil during sepsis. Meta-analysis, sensitivity 76%, specificity of 85%. Promising but limited by high cost and labor-intensive testing. Then pentraxin, that is PTX3, pattern recognition molecules released by immune cells. PTX3 has immune modulatory and antimicrobial roles, reasonably sensitive for 28-day mortality prediction, but not highly specific, and combining with other biomarkers may improve accuracy. Calprotectin, that is calcium binding protein released by activated neutrophils, inhibits microbial growth and participates in inflammation, more accurate than PCT for bacterial infections in ICU cohorts, but it needs further validation before routine use. Another newer prognostic biomarkers in sepsis, that is adrenomedulin or mid-regional proadrenomedulin. That ADM is a vasodilatory peptide with inflammatory effects. Unstable in circulation, MR-Pro-ADM is more stable surrogate, correlates with severity and prognosis in sepsis, and requires further validation. Other biomarkers in critically ill patients, apart from that for the sepsis, are cardiac troponin, that is frequently elevated in ICU patients, even in the absence of acute coronary syndrome. So we have to be careful before interpreting the result. Systematic reviews show that troponin elevation is associated with increased mortality and longer ICU and hospital stay. And their primary role in critical care is prognostic and not diagnostic. Then NGAL, that is, it rises earlier than serum creatinine and is useful for early detection of acute kidney injury. That was discussed in our previous nephrology topic section also. And studies show that NGAL identifies ICU patients at high risk for AKI before creatinine changes are evident, making it a valuable early warning biomarkers. In fact, you people can get separate questions on AKI biomarkers also. Then BNP or NT-proBNP. BNP and NT-proBNP are natriuretic peptides used to differentiate cardiogenic from non-cardiogenic pulmonary edema and to assess prognosis in acute heart failure. While useful in diagnosis, their interpretation can be confounded by renal dysfunction, sepsis, and critical illness. Nevertheless, they remain helpful adjuncts in ICU decision making because anyway, their prognosis it will decide the prognosis, because if it is elevated, definitely the ICU stay is going to be prolonged. Then IL-6 and cytokines. Cytokine measurements, especially IL-6, reflects the inflammatory state in critically ill patients. Elevated cytokines correlate with disease severity and outcomes and may help phenotype patients into hyperinflammatory or immunosuppressed group. However, their clinical application is limited by assay variability and slow turnaround time. So IL-6 we are measuring very commonly in septic patients, those who are coming especially with the AKI, and we are planning to start the CRRT. In those patients, we can definitely see IL-6 level so that we can decide about the type of filter we can use. Then cell-free DNA, that is cell-free DNA is emerging biomarkers of tissue injury and prognosis. Elevated cell-free DNA levels are associated with multi-organ failure and increased mortality. So at present remains investigational with limited clinical availability. So this is the end from our side. Can I share the missing slides of diastolic dysfunction? Is that okay? If time permits?
Sure, ma'am.
Yeah, great. Okay, so mm, mm. So I think we had completed till here. Yeah. So this one was done. How to do this uh, diastolic dysfunction by tissue wave Doppler? So this is the 5-chamber view, and we will put the tissue wave Doppler. The tracing will come, and E by E prime. The second one is C. So that is where when we use the E by E prime, when there is your A is more than E, but there is some systolic dysfunction. So in that situation, you should use E by E prime. So on the top you have mitral valve inflow, this one, and below TDI, this one is mitral valve inflow, and below is the tissue wave Doppler of mitral valve annulus. And as you move from left to right, E by E prime, velocity changes as L. So this one you can see. E prime. So this one is E and this one is E prime. And you can see as you are moving, this E is very tall and your E prime is very small. So E by E prime will give you a better idea about your diastolic dysfunction when there is patient is having coexisting systolic dysfunction. So as your left atrial pressure worsens, E velocity increases and pressure in LA increases, leading to faster flow of the blood into the mitral valve of an early diastole. Inversely, as lap worsens, movement of the myocardial in the annulus decreases and E prime gets smaller. Therefore, as lap rises, ratio of E by E prime dramatically increases. So next is left atrial pressure. This you have to remember, E by E prime less than 8, normal left atrial pressure. If it is 8 to 14, indeterminate. And if it is more than 14, definitely elevated lap. So normal versus pseudo-normal. E by A ratio 1 to 2, normal filling pressure, pseudo-normal 1 to 2. But E prime normal in normal filling, and in pseudo-normal filling, E prime will be reduced. So your E by E prime ratio will be high. So less than 8, more than 15. Again, the same explanation. So this is left atrial velocity integral from each view. Trace the left atrium area, excluding the pulmonary valve, pulmonary veins, and left atrial arterial, and measure the left atrium area. So length from the center of the mitral valve annulus to the center of the superior left atrial wall. Then freeze end systolic frame 1 or 2 frames before mitral valve opening, and calculated via that volume is calculated via the method of disc or area length method. So once you are freezing it, just covering the area, you will get the options. When you will go for the measurements calculation, you will get the option for the volume assessment, and here you will get the volume part. Again, this is the same. So just your mitral valve is getting opened. Before that, you have to freeze it. Just see how it is calculating the area, and then the machine will give you this volume. Now peak TR velocity, the TR jet peak velocity reflects pulmonary artery systolic pressure. So elevated PSP is usually a consequence of the chronically elevated LA pressure, because there is a backward transmission of the to pulmonary veins, and then that causes the pulmonary hypertension. Then now color wave Doppler cursor is aligned parallel to the TR jet. So when you are focusing on the most important is all the chambers should be perpendicular, not tilted view you need. So when there is opening of the mitral valve, just there, your cursor should be aligned parallel to the TR jet, and you will calculate this right ventricular systolic pressure, that is 4 times the TR into 2 plus right atrial pressure. And it can be used to estimate. So you will, once you are putting the color wave Doppler, pulse wave Doppler, you are getting this image. And you have to calculate from here this TR jet, and that will give you the idea calculation of the mean pulmonary artery pressure. So pulmonary artery systolic pressure into 0.61 plus 2 will be your pulmonary artery pressure, which will let you know about the pulmonary hypertension. So mild PH is mean pulmonary artery pressure 20 to 40 mmHg, moderate is 41 to 55, and severe is more than 55 mmHg. And according to the 2022 ESC guidelines, PH is defined as mean pulmonary artery pressure more than 20 mmHg with PVR of more than 2 Woods unit. And severe group is defined as more than mean pulmonary artery pressure more than 20 mm of Hg and resistance of more than 5 Wood units. So this is how it is done. Obtain peak TR velocity by color wave Doppler across the tricuspid valve. Then assess IVC size and inspiratory collapse to estimate right atrial pressure, and apply to the Bernoulli's equation, that is 4V square plus right atrial pressure to estimate your pulmonary artery systolic pressure. So this is again the repetition. Now practical applications for calculating all these things is hemodynamic management to guide fluids, diuretics, vasopressors or inotropes, avoids pulmonary edema from over-resuscitation. In ventilator interactions, high PEEP may worsen left ventricle filling, identifies vening-induced pulmonary edema, Then shock states. In septic shock prevents fluid overload in cardiogenic shock. Fluid bolus may worsen shock. And acute pulmonary edema, common in preserved ejection fraction with grade 2 to grade 3 diastolic dysfunction, especially when there is a tachycardia. Then perioperative or post-operative patients, post-CABG valve surgery prone to low output. Elderly hypertensive decompensate easily, and arrhythmias in ICU. Atrial fibrillation poorly tolerated, loss of atrial kick, need strict rate or rhythm control. Or in fact, any tachycardia is very poorly tolerated if the patient is having diastolic dysfunction. And prognostic value, restrictive filling linked to increased mortality, AKI, predicts prolonged ventilation in ICU. So components of correction of hemodynamics in diastolic dysfunction include it reduce afterload, avoid arrhythmias, mainly tachyarrhythmias, use inotropes without negative lusitropism, and maintaining balanced fluid status, maintaining adequate demand supply balance for left ventricle. So this is your cardiac cycle. You all should be very well aware about this cardiac cycle. So this can be asked to anyone in the practicals also, and you should not miss this. That's it from the diastolic dysfunction side. Thank you. Now, so next, what we are. So our presentation part is over. We try to
Yes.
cover as much as possible, but yeah, of course, this lot many things are still pending. So just keep on practicing. And next questions, or we will move to next topics.
I think
Anyone?
since we are done, then we will invite Dr. Krishnan
Yeah,
for the next domain. If you can, sir, can you unmute yourself?
thank you.
Thank you, ma'am. Thank you, Dr. Ritika. Thank you, Dr. Pratima, ma'am. And since Dr. Abhinav is not there.
Okay. Shall we start? So, at the outset, let me thank Arindam sir and his team, the SATS Academy, for giving us an opportunity, our team, myself, Dr. Krishnan, Dr. Sudeshna Gupta, Dr. Vivek Prasad, and Dr. Pranshuta. We are handling the recent advances and emergency related part. We all know how important, how critical care is evolving day by day. So, along with the previous questions, past year's questions, we have incorporated some more questions along with the newer drugs, including antifungals, related immune modulation in sepsis and all. So from our part, we'll be beginning with Dr. Sudeshna Gupta. Dr. Sudeshna, please.
Hello, am I audible? Am I audible?
Yes, you are audible. You're well audible. You can share.
Should I? Yeah. Is my screen? Hello.
You're audible. You're audible.
Ma'am, you need to share the screen.
Yes.
It's a green button. It's not started yet. Just hold on. So, ma'am, there is some black mark which is coming that you have to remove. There is some. You have to close these small windows. Yeah, you have to close that also, ma'am.
This one?
Yeah, perfect. So, can you do a full
Yeah.
screen?
Yeah, sure. Am I good to go?
Okay, ma'am. Sure. Yes.
Okay, so myself, Dr. Sudeshna Gupta, I will be talking about some topics on the recent advances. These are my topics. First one is the AI in critical care, which is a very hot topic, as we often say. So first is AI in critical care. I have tried to bold mark some of the points which are must remember and need to be incorporated in my answer. So AI is a technique that replicates human intelligence, analytical behavior, and decision-making ability in machines. Applications of AI in CCM. It helps in early disease identification, predicting disease evolution, individualized treatment, optimizing the allocation of resources. We will divide about the application of AI and in different systems or different segments of critical care. First, application of AI in respiratory system. 3 studies has been done. First is application on calculating respiratory resistance and compliance. Secondly, for determining optimal timing of weaning on mechanical ventilation. And thirdly, identify ARDS phenotype. So now, 3 important studies on AI in respiratory system. Next to AI in sepsis. Again, 3 studies has been done. For early prediction of sepsis based on age algorithm, early detection of septic shock, and early detection of septic shock based on SERA algorithm. AI and COVID-19, 2 studies has been done. One is the QREAL, other is the exam study. QREAL was done for COVID-19 screening. QREAL was done for the COVID-19 screening with application of the routine test available within an hour of admission. And the exam of the EMR chest X-ray AI model was done for the estimating the need of oxygen in the symptomatic COVID-19 patients. Moving on with AI and renal system. 3 studies. One on the development of the ESRD, estimating how far we can pick up the patients who are in the progressive stage of end-stage renal disease, early prediction of AKI, and early prediction of contrast-induced nephropathy. AI and cardiovascular system, 4 studies has been done. First is the AI clinical decision support system, which is a hybrid system helping us in diagnosis of coronary heart disease. Secondly is a software generated named as heart model, which will analyze the echocardiographic parameters. Third is the VLAB that monitors patients' left atrial pressure continuously and aiding in the management of the heart failure. And fourth one is the AI augmented ECG rhythm. AI in trauma, only 1 study has been done, which some drawbacks which are prevalent in case of applications sample size and insufficient validation of predictions. An AI model, they are often done on limited data set. So it's not possible to extrapolate the data that we are getting from these studies to the normal day-to-day population. Third one, there is something called the breach of the patient privacy, because I am sharing some medical information to artificial intelligence, which can actually lead to disruption of the patient's privacy as well. And there is only some fewer AI applications still now dead, which has been validated, which are in use. So much more evidence-based studies are needed to actually predict the application of AI in critical care. I think this will suffice for our 5 marks questions, because there are pages given in the NB booklet and only 2.5 pages, I must say, needed to fill up for a 5 marks questions. These are the slide I have written extra. If there is time permits, you may go through this. What are the kind of biases that may engulf this artificial intelligence medical research? My next topic, here are some 3-4 important newer type of drugs. Among them, the first one is the angiotensin 2 or gioprasa. Angiotensin 2 is a naturally occurring peptide hormone it helps in raising vasoconstriction. phosphorylation. Been written because these are the words that need to be incorporated in my answer, obviously. Pharmacokinetics. Following an intravenous infusion of angiotensin 2 in adults, it has been found that the levels are similar at baseline and after 3 hours. It means they have to be infused over a longer duration of time. Now, plasma half-life is less than a minute. So, it means just after the IV administration, the serum level would be attained at, and the serum level will be maintained for 3 hours. Specific population, no formal studies has been done in pregnant and pediatric population. One thing to note, renal impairment and hepatic impairment. There is no dose adjustment needed in the renal impairment, no dose adjustment needed in the hepatic impairment. Clinical studies, this is, though it's been written in extra, but if you have time, please go through this. Athos 3 is the study or the trial. It's a double-blind study done on the Giapreza on the patients with adult patient with septic and distributive shock who remained hypotensive despite adequate fluid and vasopressor therapy. And doses of Giapreza or placebo were titrated to a target of MAP of more than 75 millimeter of mercury during the first 3 hours. And the endpoint was the percentage of the subjects who achieved this MAP or a target MAP or a 10% increase in the MAP without an increase in baseline therapy for 3 hours. And this was achieved by 70% of the patients who has been incorporated in the Giapreza are as well. So the median time to reach the target MAP endpoint was 5 minutes. The effect was sustained and the mortality with the benefits was also there. So this is a very much upcoming drug about the angiotensin 2 analog. Some adverse event, I would like to point out the top most common adverse event noted. One is the thromboembolic events with deep vein thrombosis, thrombocytopenia, tachycardia, fungal infection. These are the most common. Black box warning is because there has been higher incidence of arterial and venous thrombosis and thromboembolic events as was with the patients receiving this drug as evident in this study. Dosage, this must be administered as intravenous infusion, diluted in 0.9% sodium chloride prior to use, and dilute the drug in a normal saline infusion bag and a desired concentration of this semen. The diluted solution may be stored in the temperature as provided over here. Administration 20 nanograms per kg per minute, preferably through a central line. There is no contradiction, the dosage forms are given. Second drug, cefepime in Metazobactam. Cefepime in Metazobactam has mostly been in rise because of the increased incidence of the ESBLs. Now, what are these ESBL products? Enterobacterials, E. coli, Klebsiella, Proteus, Enterobacter, they are the most common of infection, most commonly residing in the urinary tract. However, they can also be detected commonly in the hospital-acquired infection or the ventilator-associated pneumonia as well. But the concerning among this is the rapid spread of the extended spectrum beta-lactam producing enterobacters because they mediate the resistance to third and fourth generation cephalosporin as well as Aztreonam. And in them, the use of peptides is controversial as we have evidence from the Merino trial. Therefore, a therapeutic need always exists for a non-carbapenem antibiotic alternative that can target this CSBL producing bacteria and can well act against the chromosomal AMC overproducing bacteria. So why cefepime immetazobactam was actually needed for us? Because on one hand, the ESBL organisms were inherently resistant to the third or fourth generation cephalosporin. At the same time, this enmetazobactams of BLI was necessary for denting the resistance. So the mechanism of action, the cefepime is a fourth generation cephalosporin, which is a broad spectrum bactericidal and already in vogue for uncomplicated treatment of uncomplicated UTI, complicated UTI, pyelonephritis, intra-abdominal infection. They mostly target the penicillin binding protein 3 in the gram-negative bacteria, and they have a stability against the extended spectrum of AMC producers as well as the OXA48. So cefepime, though being a fourth generation, this is a twist that cefepime, though being a fourth generation cephalosporin, they have enhanced stability against AMC and OXA48. On the other hand, Enmetazobactam is a novel penicillinic acid sulfone beta-lactamase inhibitor BLI, which is similar in structure to tazobactam, but strategically the methyl group has been placed so that it increases the bacterial cell penetration, and it allows for many classical and non-classical hydrogen bonding interaction, which are normally not observed if the tazobactam would have been in place, especially for the CTXM generated. So thus, they becomes a potent inhibitor activity against all of them, CTXM, TEM, and SHB, ESBL, and all other classes of A-beta lactamases. One thing we have to keep in mind that enmetazobactam has no activity. I have kept it in the red letters against the class B beta lactamase. For class C and D, even it has a less of a direct impact. So this kinds of drugs has been developed for the ESBL, preferably for the class A type of beta lactamase like CTXM, TEM, SHB, ESBL. There can be some mechanism of resistance to cefepime enmetazobactam as well, via porine mutations and via this metallo-beta-fructose link. Usage in the US, United States is used mostly in the complicated UTI, including pyelonephritis, while in the European nation, the spectrum has extended over pyelonephritis, complicated UTI, hospital-acquired infections, including the VAP. The clinical efficacy has been very good against the Pseudomonas aeruginosa and enterobacterials, and cefepime is suggested for the treatment of infection caused by the moderate risks of significant AMSI producer kind of organisms. So this has been developed primarily for the treatment of ESBL producing enterobacterials. Contrary to the recently commercial antibiotics, I won't name them, it doesn't demonstrate a strong activity in the CRE, except for the OXA48. As I have told earlier, the cefepime has inherent stability. This is just written below in the brown also. When cefepime has got good antibacterial activity against the enterobacterial infection, but it was not having a good spectrum against the ESBL. While when we add the enmetazobactam to this, the MIC changed, as we can see over here. So for the treatment of pneumonia, cefepime is a very much preferred option because of its good penetration to lung tissue, especially for the KPC isolates, which become resistant to ceftazidime and remain susceptible to this. But this needs to be obviously supported by clinical evidences as well. Consideration is mostly three things. One is limited activity against anaerobes, limited effect on the digestive microbiota, known neurotoxic of cefepime, especially in cases of VAP, because the dose is as high as 6 grams per day. So that needs to be taken into effects. My next drug will be the cefiderocol. This is a novel catechol substitute siderophore cephalosporin, which is structurally similar to cefepime and ceftazidime. Mechanism of action. Each point is important because this is the only drug that has been evolved to bind to the extracellular free iron and uses the bacterial active iron transport channels to penetrate the outer cell membranes. They act via siderophore, which is very much important in imparting them their ability to destroy the resistance mechanism of a large number of the GNB, including the efflux pump of regulation porine channel mutations. Thus, FDA was already approved cefiderocol in 2019 for the treatment of complicated UTI, hospital-acquired pneumonia, and ventilator-associated pneumonia. And by 2020, European Society also has treatment of infections in MDR aerobic gram-negative bacteria. So it's a novel cephalosporin with a promising activity against MDR GNB, especially the CRE groups, the carbapenem resistance gram-negative bacilli. It would be useful for the treatment of the gram-negative bacilli with limited therapeutic option, as well as producing metallo-beta-lactamase. This is very much important. They would be efficient for the metallo-beta-lactamase for the VIM NDM variety. Very small or very few options we have when it comes with the VIM NDM variety positive of CRE bacteria. Further evaluation in phase 3 clinical studies are necessary in order to evaluate its efficacy as well. Clinical trial, 2 clinical trial on this. Apex complicated UTI, where it has been done on phase 2 multicenter double-blind parallel group non-inferiority study with a clinical diagnosis of complicated UTI plus minus pyelonephritis contrasted against the imipenem celastin. The most prevalent GNB isolated by E. coli and Klebsiella. Primary efficacy achieved by 73%, and it was a non-inferior study. So it was shown that cefiderocol 2 gram TDS was non-inferior when compared to immunosilacin. The second one is still under it's named to be a game changer. The results are still under progress to compare the 14-day mortality of a 2 gram regimen given over 3 hours TDS for a period of 7 to 14 days. Third one is the sulbactam darlobactam, another new. Sulbactam darlobactam is a new BLI combination. The first is the BLI combination. Both are BLI combination with the activity against the multi-drug resistant Astrobacter baumannii. Everyone working in the intensive care unit are dreadful with this MDR bugs. And when it comes to the MDR Astrobacter baumannii, we just keep our fingers crossed. It is indicated in patients 18 years of age and older who have limited or no alternative treatment options for the treatment of hospital-acquired bacterial pneumonia or the ventilator-associated bacterial pneumonia. Specification that IDSA guidelines are very much strict about that for recommendation, either a carbapenem or high-dose sulfabactam as a weak, low-quality recommendation for the treatment of HAP or VAP caused by the susceptible Acinetobacter species, and strongly recommend either one of the polymyxins. What is the mechanism of action? Sulbactam, all we know, is a first-generation beta-lactamase inhibitor with a direct activity against the baumannii species, and excuse me, and in high doses successfully reaches the penicillin-binding protein targets of the Bohm isolase. According to the guidelines, what we have just studied, the sulbactam is a preferred empirical agent to treat suspected baumannii species, but with the increase of the Acinetobacter resistance to this sulbactam and carbamazepines, there has been studies going on in incorporating or mixing with some other cefoperazone, tigecycline, polymyxin to add of them too. So darlobactam has a broad spectrum activity against the amyloid ACD serine beta-lactamase, and thus with the emergence of resistant Acinetobacter species, the development of novel agents was crucial. In the pharmacokinetics and dynamics, they have relatively short half-lives, they are rapidly distributed, thus they need more than one dose, necessitating multiple doses. Like other beta-lactam BLI, sulbactam darlobactam is mainly eliminated through renal restoration, thus renal dose optimization is necessary. This is very much important. Clinical studies, the ATTACK trial, the name of the trial is ATTACK. Kaya et al. Has evaluated the efficacy and safety of the sulbactam darlobactam versus colistin with serious infection caused by the crab, the carbapenem resistant Acinetobacter baumannii in the ATTACK trial, randomized active control non-inferiority study. And it has shown promising results for the treatment of even the colistin-resistant infection. Adverse events include the deranged LFT, diarrhea, anemia, hypokalemia, and neutropenia may often be. About the doses, sulbactam darlobactam, as I mentioned earlier, creatinine clearance adjusted, dynamic creatinine clearance adjusted doses is very much important. So we have to adjust our doses according to that. So this is restricted now applies in therapy. So this is restricted use in the treatment of hospital-acquired pneumonia or ventilator-associated bronchopneumonia by susceptible isolates of Acinetobacter baumannii complexes. And another use may be in the cases of complicated UTI, but nowadays it has also been shown some promising results with the combination of sulbactam, darlobactam additional to the cefoterazone. So this should be considered. It has been before the use of polymyxins from the use of ABCs, particularly in patient at high risk of nephrotoxicity, but at the same time, sulbactam, darlobactam is also renally excreted. So the use are very much restricted. Only especially I can see in the colistin resistant bugs, this can be used. The drugs are completed. Next is a molecular diagnostic in the sepsis with a focus on mostly the BCID panel or the biofire. Now, sepsis, as we all know, a serious and life-threatening condition. Patients presenting with a malaise, fever, chills, some vague symptoms, but we need some urgently to evaluate the patients for the presence of the bacteremia by using the blood culture analysis. So in the absence of the robust diagnostics test, obviously there will be more utilization of the broad spectrum antibiotics and more use of the antibiotics even in those scenarios where there was no evidence of infection as well. So our ideal diagnostic test, or I must say it shouldn't be the ideal sepsis diagnostic test, our ideal rapid diagnostic test. What should the features of it? It should have rapid detection, number one. Number two, broad-based detection. So it can detect bacteria, virus, fungi, a large minimal invasiveness, high sensitivity and specificity. It should have a polymicrobial detection of pathogens. Detection of drug resistance, clinical workflow, ability to distinguish the inflammatory response. Limitations. First is the limitation of the standard blood culture methods, because the blood cultures takes time. That was the main and the chief reason why these PCR tests, why this BCID panel, why this BioFire or the polymerase chain reaction tests are in vogue, or we need them. So this is basically a FDA approved test, which is these are the names of the companies, the BioFire Flame Array Blood Culture ID panel that uses the multiplex PCR to identify around 30 type of bacterial fungal pathogen and 10 type of genes. It has a 99% sensitivity and 99.8% specificity. What are the most common pitfalls? Now we have heard a lot about why BioFire is important. I will first show why I need to be cautious about the BioFire result. First, pathogens are identified at the genus level. So it will just show me is a staphylococcus or a streptococcus. What I need to identify that there may be some inherent commensals in between them. There may be some picked up of the dead viruses, it may be there. And because BioFire will show me a cluster of the organisms. So if I just see pathogens detected, a long list, pathogens not detected, few are there, definitely are there. Why ID is being consulted with this? So why we often depends on the infectious disease specialist or how to implement this BioFire. Because studies have demonstrated implementing the stewardship practice alongside the rapid diagnostic test will significantly improve the patient outcomes. Because just I have told, the main two pitfalls of this BioFire or this PCR test are the pickup of the viruses or the bacteria and microorganisms, including the commensals, including the dead virus, especially which happens in the respiratory panels. Next is the molecular diagnostic in the sepsis, the MALDI-TOF. MALDI-TOF, as we all know, is a technique which is used to identify microorganisms by analyzing the mass spectrum of their proteins. The advantages are the rapid, accurate identification of bacteria and fungi. The most three important applications include microbial identification, antimicrobial susceptibility testing, identification of rare or novel pathogens. Now, why we are excited of this MALDI-TOF? What extra it gives us? This is faster, better, cheaper identification of a wide range of microorganisms. So obviously it will give the following benefit: decreased time to detection of pathogens, directed patient care, antibiotic stewardship. And it has shown consistent and comparable results between the labs and ships. So why we should change? If we just compare on the basis of traditional way and the MALDI-TOF, first is a decreased time, decrease the training, less skill is required, so less step of learning, the learning curve is less, different technologies, different IDs is better, equalizer of between the shifts. Sample preparation, spot the target site with direct colonies, add some matrix solution. How a MALDI-TOF sample is done: load the target site, spread a spectra and get it done. This can also be applicable. This is not in vogue in our countries, but it is mostly in vogue in the Western, that once the blood culture gets positive, inform the nurse and put the sample on the MALDI-TOF as well, so that I can get the earliest detection of the organism and de-escalating the antibiotic or escalating the antibiotic, especially making it the narrow spectrum use. No test it perfect, definitely. What is the problems with this MALDI? Like E. coli versus Shigella, very closely related, cannot be differentiated. Streptococcus pneumonia versus Streptococcus mitiscum, again very closely related. Bordetella pertussis versus Bordetella bronchioseptica, very closely related. So there are some like Streptotopomonas, Astrometa bowmani. This species differentiation is difficult with MALDI-TOF. So why we need to change? Against validity of health in antibiotic stewardship, validity of cells in automation, less medical waste, cost is less, cost to healthcare system is less, FDA approval is still not there for the mandate of as well. While BioFire or the BioAd is already FDA approved. The molecular diagnostic in the sepsis, expert Karbar assay. This is the thing which we often come across and often do in our intensive care units. Multi-resistant bacteria become a healthcare problem. Mostly we have, and one thing I need to find out, there are two group of organisms. One is the carbapenems producing organisms, which are again a nightmare to us, CPO, Pseudomonas aeruginosa, Astrobacter baumannii, as well as the carbapenem resistant Enterobacteriaceae, CRE, including the E. coli, Klebsiella, and Enterobacter cloaca, again a nightmare to us. So this expert Karbar assay is a qualitative in vitro real-time PCR assay, which helps us to detect the gene that is causing this carbapenems gene. Carbapenems production includes the IMP, KPC, Indium, OXA48V. How the culture is proceeded, the specimen considered is positive in the expert Karbar assay if at least one of the carbapenems genes was detected, while negative if none were detected. There was in the largest study where this Karbar assay was done to compare this about the validity of the test or the validity that when gene is been picked up by the Karbar assay, how much it is correlated to it picking up in the specimen culture. It will shown that 38 were positive for CRE by the culture test, and among them 30 CRE positive. E. coli was isolated 14 specimens. So Karbar assay, in short, in a nutshell, it has high sensitivity, high specificity in use. This was the actually studied as I was discussing. So it shows it has a performance which is almost in relation with the culture based method as well. So what's its utility? Why this is necessary? This is a reliable and accurate multiplex qualitative assay which is suitable for the rapid detection of such organisms because the antibiotics need to be optimized. In the broad spectrum antibiotics, we often use the carbapenems or the BLBS, which will not act if a CRE organism is detected. And again, among the CRE organisms, the genes need to be detected, and accordingly the antibiotics need to be optimized as early as possible. So to cut short into this as early as possible time gap, this Karbar assay is extremely necessary. This is against the and some false positives. Obviously, it can come because of culture method limitations, patient receiving the antibiotics before inhibition of the growth, anaerobic fastidious organisms. Some false negative can also be there, like low bacterial load, mixed colonies, negative results. Some limitation that doesn't indicate the bacterial identification is not a subtyping. Results might come invalid. Performance of pediatric patient is not known. The stool samples are not known. CRE anaerobes may be present are not evaluated. So maybe there is some limitations, but Karbar assay is an extremely useful tool in our day-to-day practices. This is my last topic, surgical blood conservation, which though not much in work, but it can come as a short note of 5 marks questions. Intraoperative blood salvage therapy. These techniques reduce the patient exposure to allogenic blood during and after surgery. The techniques include preoperative autologous donation, intraoperative hemodilution, and surgical blood salvage. Indications. Number one, major surgical procedures with an expected significant blood loss. The rationale is stronger for an expected blood loss of more than 1 liter, reasonable for 500 to 70 ml. Number two, patients of Jehovah's Witnesses who decline the allogenic blood transfusion. Number three, situations when cross-match compatible blood cannot be obtained. Number four, it reduces the need for transfusion of allogenic RBCs. So allogenic RBC transfusion in the high blood loss procedures, we can use this method. Provision of more RBC units with lesser time and cost savings as well. Few contraindication of this intraoperative blood salvage, presence of contraindicated fluids, admixture with the hemostatic products or bone cement. Relative contraindications include bacterial infection, active malignancy, hemoglobinopathy, coagulopathy, transfusion associated circulatory overload. Procedure, first is a suctioning of the shed blood, centrifugation followed by washing of the RBCs, eventual reinfusion to the patient. Thank you for your patient listening. Thank you.
So thank you, Dr. Sudeshna. She has discussed in detail about various topics like AI in critical care, the newer drugs, various she has already discussed the molecular diagnostics, blood conservation in surgery. So, does the participants, any of the participants, have any doubts or clarifications? Shall we go to the next speaker? I think.
Yes, sir.
Okay. If there are no clarifications, we'll go to the next speaker. I think Dr. Pranchuta, are you ready? Please unmute yourself.
Yes, sir. Good evening. Sorry for the delay, sir. Can you please tell me how to share the screen?
So there is a green button, ma'am. You see in the middle, there's a green button when you go to Zoom.
1 second. I'll find it. Share.
Okay, in Zoom, when you go here, share, and then you click the OK button. Then share. Just you click, once you share, then again click the share button. Click on the green button,
Yeah, I've clicked on it. Okay.
and then another time there will be share button which will come. So you have to click on that, then only the share will happen.
One second.
Ma'am, you just have to click on the green button, share.
Yeah, I did it, but it's not opening.
And then the second when it comes, there's if you can do one thing,
Yeah.
your pop-up blocker has to be there. It's on the right hand, top right hand side.
It's not showing me actually. Anything else which can be done?
Ma'am, you share me the presentation first. By any chance, Dr. Unni has your presentation?
No.
So, ma'am, you have to share it with us, or you have to open the pop-up blocker, because I think if you're not able to see the next pop-up, the Zoom, then it's blocked.
Shall we proceed with the next speaker so that
Yes.
Dr.
Yeah.
she can share the.
Yeah, that will be great.
Okay, Dr. Vivek, can you take over?
Okay, so I'm going to share my presentation. So is it visible?
Yet to come 2 minutes.
Hello.
Full screen, sir.
Full screen.
Full screen. Perfect.
Okay. So, 1 minute. So, good evening, everyone. I'm Dr. Vivek. So, I'll be dealing with additional must-know recent topics, which includes my topics are the cytoscope or the heme absorption techniques. The next one is the tele-ICU, and the third one is mRNA vaccines. So, coming to the first topic, cytoscope or heme absorption devices. We'll first discuss the types of the heme absorption procedures and the rationale regarding the cytokine removal in sepsis, COVID-19, liver failure, and the current trial evidences pertaining to all this. So regarding key heme absorption techniques, there can be 3 kinds of heme absorption techniques. First is the endotoxin removal. Next is cytokine adsorption, and third one is combined or hybrid system, which includes both endotoxin and cytokine adsorption. Endotoxin removal and cytokine adsorption. So regarding the endotoxin removal, we have already heard about the polymyxin B immobilized fiber, also known as toremyxin. In this, the polymyxin B antibiotic is embedded in a fibrous material because the polymyxin B has a high affinity for the endotoxin produced by the gram-negative bacteria. It is immobilized in the polystyrene fibers. It directly binds and removes the endotoxin from the blood of the patients with gram-negative sepsis. So the target here is the endotoxin, which is a lipoprotein. Next method is cytokine absorption via porous polymerase beads, also called the cytosoap. Its strain name is cytosoap. The mechanism is a non-selective column with biocompatible, highly porous polymer beads, which captures cytokines and hydrophobic substances in a concentration-dependent manner. The target is cytokines, mainly interleukin-6, TNF-alpha, and also products like bilirubin and bilirubin liver failure, and also myoglobin. These 2 mechanisms, endotoxin removal and cytokine absorption, is combined in the third combined or hybrid system, which is named as OXIRIS, which includes the AN69 membrane. In this, the hemofilter is combined with the standard renal replacement therapy, and the absorption capabilities of both cytokine and endotoxins occur. We'll go to the pictorial representation of all the 3 so that you can understand how the mechanism occurs. So first one on the left diagram shows the toremycin resin, which embeds the polymyxin lipopolysaccharide. And the second one is, as I mentioned, the cytosoap, which is embedded in the CRRT machine. And after the convection and diffusion, the adsorption occurs at the cytosoap material. Next is the OXIRIS membrane. It includes a 3-layer membrane. First layer is the AN69 copolymer hydrogel, where the cytokine is captured. Second layer includes the polyethyl imine, which captures the endotoxin. And third layer is the heparin grafting, which reduces the formation of thrombus, or the prevents the coagulation of the blood. This is a 3-layer OXIRIS membrane. So what is heme adsorption? Heme adsorption is an extracorporeal blood purification therapy designed to modulate the dysregulated host inflammatory response, especially in sepsis. It is designed to remove the pathological substance from blood, such as cytokines, bilirubin, myoglobin. The primary device is cytosoap, and the mechanism, as we mentioned, endogenous and exogenous substances from blood via adsorption. Regarding the regulatory status, Europe has a broad CE mark for all the conditions with elevated cytokine levels for application of cytosoap, while USA has a FDA emergency use during COVID, especially in COVID, but not full approval for sepsis. In cytosoap, the material contains a biocompatible porous polymer beads with a massive surface area of more than 45,000 square meters, And it includes two core principles: the size exclusion and the hydrophobic absorption. Size exclusion is the pore allows molecules of approximately 5 to 60 kilodalton to enter, which includes the cytokines, PAMPs, DAMPs, myoglobin, and bilirubin. And the larger particles like the albumin, which is more than 66 kilodalton, are spared, and it passes through also the immunoglobulins. While hydrophobic absorption means the target molecules bind to the polymer surface and are irreversibly removed, and this process is concentration dependent, being most efficient at the pathologically high concentrations. So regarding the rationale, the fundamental goal is to interrupt the vicious cycle of systemic inflammation leading to multi-organ dysfunction. As we all know that in sepsis, a dysregulated host response due to the pertaining infection will lead to production of massive amounts of cytokines and leading to a cytokine storm, the formation of PAMP, DAMP, or which in turn will lead to organ damage and multi-organ dysfunction. And this cytosol or the hemoabsorption method will remove the massive cytokine storm or the cytokines and also the PAMPs and DMPs and prevent this inflammatory molecules from damaging the rest of the organs, resulting in moods. Also, in liver failure, it also helps in removal of the metabolic toxins like bilirubins, bile acids, which causes direct cell injury. So blood purification therapies target at first removing the pathogens from blood, second from removing the endotoxins or the PAMPs, third by removing activated leukocytes or reprogramming leukocytes, and fourth by reducing the cytokine blood levels. So regarding each of the indications for cytosol, the first and foremost indication is sepsis and septic shock, for which is most widely used and most controversially applied. Regarding the trial data, we can see that all the observational data and the registries, all the observational studies have given consistent reports of reduced inflammatory markers post cytosol application and also improved hemodynamics with reduced vasopressor levels needed after administration of cytosol in sepsis, and also a faster lactate clearance. A 2025 meta-analysis of mainly observational studies by Stein et al., which includes 744 patients, showed a significant mortality benefit with in-hospital mortality of odds ratio of 0.64 and 28 to 30-day mortality odds ratio of 0.49, which both are significant, and also demonstrated significant reduction in vasopressor requirements. Also, a single large center study including 175 patients showed lower actual ICU mortality of 49% than the predicted SAP scores of 66%. All these observational studies have shown a significant effect of cytosol application in sepsis. But in contrast to that, all the high quality evidences or RCTs, especially the landmark REMOVE trial by Scheidler et al. In JAMA 2017, has shown no significant improvement in 60-day mortality after application of cytosol and no significant reduction in IL-6 levels. And there was a trend for higher mortality in case of cytosol group. A comprehensive 2023 meta-analysis of 17 RCTs by Heyman et al. With 855 patients found that no significant reduction in IL-6, C-reactive protein or procalcitonin occurs, and a statistically significant increase in mortality also occurs after application of cytosol. So no RCTs are in line with use of cytosol, but observation studies are there. So in case of sepsis, we can't completely rely on cytosol, but still in some centers cytosol is being used. It's FDA approved, and in some cases in Europe also it's being used. So there's evidence conflict. There's a major disconnect between promising surrogate endpoints in observation studies and failure to improve the hard clinical outcomes in high quality RCTs. Meta-analysis remain conflicting, with some suggesting benefit in subgroups, others showing no benefit. And based on the high level of evidence, that's the RCTs, routine route of hemoabsorption and selected patients with septic shock is not recommended. In acute liver failure, there is dual rationale. There's a supportory excretory function that it helps in removal of accumulated bilirubin and bile acids, and the most consistent and positive evidence is for cytosol in the management of hyperbilirubinemia, and also it modulates the inflammation by controlling the systemic inflammatory response. Strong supporting evidence with meta-analysis in 30 publications, including 335 patients, confirmed a significant reduction in total bilirubin levels, and also a Vienna General Hospital study in ACLF patients demonstrated 47.8 reduction in bilirubin. Cytosol also showed a bilirubin elimination rates comparable to established liver support methods like MAS and the ADVOS. So, in acute liver failure, cytosol had a definite indication and has a strong evidence to support that, and it's also indicated up to date. It is being used as a bridge to recovery and bridge to transplant for stabilizing the patient. And it is still there is chances for RCTs on this, but all the major studies have been a positive result in acute liver failure for cytosops administration. Other applications in severe COVID-19. Earlier, the emergency use approval was given on cytokine storm, but the evidence is limited in observational data only in this also, and was not established in any RCTs. The key findings include the PSYCHO trial, which include ECMO patients with COVID, which showed that there was higher mortality in cytosol group compared to the control group. And a German study, nationwide German study, also found a higher in-hospital mortality in heme absorption compared to matched controls. And there's in one study, it showed that there was a potential rationale for harm, unlike in bacterial sepsis, because in COVID-19, the baseline cytokine levels were much less than the acute bacterial sepsis induced cytokine level. So there was a potential harm also. So the systematic reviews confirmed that trials have been inconsistent, neutral, or negative, and there is a possibility of harm in case of application of cytosol in COVID-19. In cardiac surgery, there's a proposal that it could remove inflammatory mediators and anti-inflammatory drugs post cardiopulmonary bypass, but the evidence is not so good and still emerging. Clinical considerations and safety profile. The patient selecting and timing are critical in cytosol. The best responder patients may be the patients with very high baseline cytokine levels, and early initiation of therapy within 48 hours appears to be more beneficial than a delayed treatment. Adverse effects. The main adverse effect is thrombocytopenia due to platelet consumption, and also removal of essential proteins like albumin and fibrinogen. Complications. Main complications are the non-specific antifungals, and also these all result in subtherapeutic level of these drugs. And so therapeutic drug monitoring is advised during application of cytosol, and also if necessary a supplemental dose of antibiotic is to be given post cytosol application. Regarding anticoagulation, the systemic anticoagulation is being done in most of the cases, but it increases the risk of bleeding. If possible, regional anticoagulation is preferred. Other thing is that this therapy is expensive. It drains the cost and the resources and requires trained personnel for application of this heme absorption techniques. So coming to the last part, in conclusion, heme absorption is a therapy with strong pathophysiological rationale and proven ability to remove target molecules from blood. But the evidence verdict is that in sepsis, high quality evidence does not support its routine use to improve survival. In COVID-19, the use is contraindicated based on current evidence, which points to a lack of benefit and significant safety signals of increased mortality. In liver failure, it's a biochemically effective support for therapy of hyperbilirubinemia, with its role in improving survival under investigation. In the future, pertaining to the cytosol is that there is ongoing research. This is Cosmos registry. Cosmos registry is a registry which includes cytosol techniques or in cytosol using patients for in sepsis or acute liver injury patients, so that the outcome is being assessed for the next 10 years, and also the CytoHep trial, which includes the use of cytosol in acute on chronic liver failure. These two, the Cosmos registry and CytoHep trials, are the coming trials which could further define the specific patient phenotypes, optimal timing, and dosing protocols which can benefit from this technology. Other option is that the path forward is the precision medicine approach. That's identifying the right patient with biomarker guided at the right time, right dose, and in that cytosol could play a major role. And further, large independent RCTs to be considered for like individual basis to mention any specific advantage in case of sepsis regarding this. So coming to the main studies, listing of the main studies, and in the first part, the toramycin or the polymyxin B immobilized cartridge. The major studies are the UFAS trial, Abdomix trial, and the Euphrates trial. In UFAS in 2009, UFAS, there was a significant reduction in 28 and 60-day mortality. But in Abdomix and the Euphrates, there was no significant reduction in 28-day mortality, and so Euphrates no survival. And Japanese phase 3 trial 2016 showed no significant difference in abdominal sepsis, but there was some reduction in 28-day mortality in septic shock patients. So on a whole, there is no much of an recommendation for polymyxin B immobilized resin or toramycin resin now, as per the contradicting studies. And in cytosol, almost all the studies have a significant high mortality rate and no difference. So all the studies are equally not effective in case of sepsis. In Oxalis, that's the double mechanism, cytokine removal plus heme absorption technique. There was a significant reduction in SOFA score, decrease in 28-day mortality in all the studies. So Oxalis is compared to be better than the cytosol and the primarily the cytokine removal and the endotoxin removal. The combination is considered to be better. Oxalis is considered to be better as per the current studies and the RCTs. These are the study aggregation, and that's all regarding the heme absorption techniques. Now we'll come to the next topic, that is tele-ICU and remote monitoring, the models of implementation, outcomes and challenges in India. So in the WHO definition of telemedicine, the telemedicine is that the telemedicine is the delivery of healthcare services where distance is a critical factor by all health professionals using information and communication tools for exchange of valid information for diagnosis, treatment, and prevention of disease and injuries. This is a technology to provide critical care expertise and support from a distance, connecting remote experts with bedside teams and patients. So what's the relevance in India is that it addresses the significant disparity in the critical care specialists to the population of India. It is seen that there's an urban-rural divide in critical care. That's 80% of physicians serve only 28% of the population. That's they are all serving the urban population only. And the severe mismatch of the trained intensivists. There are only 6,000 intensivists, mostly residing in urban areas, while 5 million ICU admissions are done annually, and majority of them are from the rural side. So in rural areas, there's no intensivist to take care of the patients. So this mismatch is to be corrected by the tele-ICU approach. So this tele-ICU is not now a luxury. Now it's a bridge between the urban and the rural divide and provides equitable care to all persons to the critical care physician. So what are the models of tele-ICU delivery? There are basically 3 types of models based on the architecture, based on the operation, and based on the coverage. The architecture model are the centralized hub and spike model, in which there's one central command center with an intensivist and multiple spokes of or multiple areas with a trained healthcare personnel or a doctor addressing to or communicating with the central command center. Other model is the decentralized architecture model, in which the experts provide consultation on a case by case. That's a proactive, it's a reactive kind, not a proactive, it's a reactive kind of mechanism by which once the consultation comes in, the intensivist will communicate with that center by tele-ICU and then sort it out. So this is not a continuous or active model, it's a reactive model. The operational other models are as per the operational models are the open, closed, and the hybrid models, as we see in our ICUs also. Open means the tele-intensivist acts as a consultant making recommendations, but the primary physician will be in charge of the bedside orders. So he can only make recommendations. In a closed model, the tele-intensivist directly take care of the patient, and the primary decisions are made by the tele-intensivist only. But in hybrid systems, a blend of both happens. The recommendations are being done. Plans are also taken to some extent by the tele-ICU intensivist. Coverage, there's a continuous covering proactive model that's 24/7, which includes the hub and spike architecture model, and episodic reactive model as the decentralized model. That's on-demand consultation for specific issues or emergencies, which is commonly done in decentralized models. So this is the pictorial representation of how a tele-ICU works. We can see the central hub where there's an intensivist at a remote location, and from this all spikes or all the peripheral centers, the data is being transferred with an on-site health provider with bidirectional audio-visual link, information management, that is the EMR and the data management. And all this requires reliable network connection and the timely communication with the intensivist by the on-site health provider. So coming to models in specific, that is the hub and spike model. This is the most common model followed in India, which as I mentioned, a centralized hub with 24/7 coverage, continuous proactive model to multiple remote ICUs called spokes. Structure is equipped with multiple monitors. That's the hub is equipped with monitors, real-time displaying data, high definition two-way audiovisual communication, real-time streaming of patients' vitals and the bedside monitors, and integration of the EMRs and all the labs, imaging and notes are accessible to the central console intensivist. And also it also integrates smart alerts and systems and alarm systems. That is AI integration is now being done, and smart alerts can be given to the central console intensivist. And the function is that standardizes the care, enables efficient use of specialist manpower, and facilitates early intervention through algorithm-based smart charts. The examples are the Critinext elastic corporate setup software, and the Cloud Physician. It's an agile tech-focused government and private sector, which has been, these two are the now applied softwares, and the tele-ICU is being conducted in India. Secondary model is the decentralized consultative service, where a virtual network of specialists. In this, more than one consultant will be there in a panel, and it's a reactive model because on demand these intensives will be alerted, and they will see in a case by case, issue by issue manner than a whole 24/7 coverage. It's only when requested by the bedside team. Prevalence, it's less common in India, and for comprehensive ICU management, because it's more of a hub and spike is followed nowadays in tele-ICU model in India currently. The outcomes and impact, the main outcome, clinical outcome, is that there's significant mortality reduction, and with figures from 40 and 59, it has come down significantly from 59 to 40. And reduced length of stay, it optimizes bed turnover, and also the length of stay is optimized to less than 2 days after application of this model. Decreased adverse effects, there's reduction in the occurrence of cardiac arrest and hospital acquired infection due to the active monitoring of the intensivist or the trained physician. And improved quality of care, it ensures consistent adherence to evidence-based protocols and best practices like sepsis bundles, swab prevention, etc. Other operational and socioeconomic outcomes include reduced patient transfers. This model enables the peripheral hospitals to manage. If a patient is sick in the periphery, he can be managed by the tele-ICU model of, there itself by the tele-ICU. The care which he receives in the higher center could be delivered to the hospital in which he is through the tele-ICU model. And also increase revenue from the spoke hospitals. All these peripheral hospitals where ICU being their revenue is not increase. Hello.
Yes, you are audible.
Did I get disconnected? Hello.
Yes, sir. Your bandwidth is low, so you can switch off
Oh,
your video. I think that will be better.
okay.
And sir, you have to do
Okay,
the full
now
screen.
one minute.
Dr. Vivek?
Yes, 1 minute. 1 minute. I'm trying to connect this. Are you able to screen my share? See my share screen now?
Yes, sir. We can
Slides are
see that. Yes, yes, we can see that. You just have to do full screen.
okay. Is it okay now?
Not yet. Yes, it's
So
again the full screen went away. Yeah, now it's okay.
now it's full screen, no? Yeah.
Perfect.
Okay. Okay, so regarding the operational and socioeconomic outcomes, I have mentioned the reduced patient transfers, increased revenue from the spoke hospitals. Hope you heard that the increased revenue from spoke hospitals because of the increase in the patient management at the spoke hospital itself from by the tele ICU physician, and reduced patient expenditure, and that's by eliminating the need for transport and urban private care, and also staff upskilling due to continuous and real-time mentorship and education for the bedside local team. So, coming to the challenges to the widespread adoption, infrastructure and policy challenges. That's one thing is connectivity. Poor and unreliable low-width internet connection in the rural and semi-urban areas can lead to major technical barrier, and lack of interoperability. That's the absence of standardized electronic medical records prevents seamless data aggregation analysis, and also regulatory ambiguity due to national telemedicine guidelines and primarily focused on outpatient care. There's a gray area between the legality of the telemedicine, tele-ICU physician taking care of the patient in another hospital. So it's also a ambiguity in legal terms, and also the significant capital and operational expenditure which is involved in setting up the tele ICU is much more higher, and it can be prohibitive for smaller institutions to make tele ICU possible. Other one is the human and organizational challenges. There could be conflict with the open ICU model, which is prevalent in India, where the admitting physician has the final authority, and there can be a clash between the tele-ICU's remote command center, and it could create a clinical friction. There could be resistance to change by the bedside staff because of to perceive and this because they could behave that there could be a continuous surveillance from someone else and could be threat to their autonomy, leading to poor adoption of these techniques. And also the digital literacy and the training gap. That is the varying technological information and comfort for the staff and the doctors working in the spoke hospitals can lead to the discrepancy, and also the effectiveness could be reduced. So these are the challenges. So in conclusion, tele-ICU presents a powerful solution to bridge the gap between the critical care gap in India, with proven benefits in reducing mortality and length of stay. However, successful nationwide implementation is hampered by the significant challenges related to infrastructure, regulation, cost, and systemic barriers. The future of tele-ICU in India depends on strategic public-private partnerships, development of a robust regulatory framework, and integration of advanced technologies like AI to overcome the existing hurdles. So, next topic is mRNA vaccines and ICU implications. the immune response, critical considerations, and rolling public pandemic preparedness. So regarding mRNA revolution and ICU, the mRNA vaccines had made a revolutionary technology in vaccinology and critical care after the advent of the COVID pandemic. They have developed that there's a need for rapid development of a vaccine through the mRNA incorporation technology, and the primary impact is that the only preventive and keeps the patient out of the ICU. That's a high number of overloaded patients with COVID could be regulated by administration of vaccine to the masses. So the secondary roles to the intensivists has occurred after the mRNA vaccination. That's managing complex breakthrough infections in vulnerable patients, but avoiding a massive load of the patients from the initial disease itself. So understanding attenuate responses in critically ill and immunocompromised is the main factor to be involved by the intensivists, because in critically ill and immunocompromised, the effect of the mRNA vaccine will be less, and diagnosing and managing rare but severe adverse effects related to mRNA vaccine. The strategic importance is that it's a cornerstone for future pandemic preparedness. So the mechanism is that how we can how the mRNA vaccine mechanism occurs after administration is that the core component is the synthetic mRNA encoding a target antigen, that's the SARS-CoV-2 spike protein, which is packaged in a lipid nanoparticle. This lipid nanoparticle function is that it protects the mRNA from degradation and facilitates for a faster cellular uptake and endosomal escape into cytosol. And this mRNA is being read by the ribosomes, and they synthesize the antigen in situ. And this mimics the natural infection to a person, presenting the antigen via both MHC class 1 and 2 pathways. The key feature is that the mRNA is transient and does not enter the nucleus and cannot alter the host DNA, and is cleared within days. And it provides a immune response in a coordinated attack model, which it triggers both the B cells and the T cells, the humoral immunity and the cellular immunity. By producing high titers of neutralizing antibodies by triggering the B cells, it blocks the viral entry and prevents initial infection. And by stimulating or by activating the T cells, it mainly the CD8 plus cells, it can destroy the infected host and host cells, and a critical second line defense to prevent the progressive diseases being made. And CD4 helper cells make a enhanced B cell and CD8 plus T cell responses, and it leads to a better secondary attack mechanism after infection. So B cell activation leads to a formation of a shield by preventing the viral entry, and T cell activation by both methods, CD4 and CD8, will lead to the tackling of the disease after infection, after contradicting an infection by an individual who is being vaccinated with mRNA vaccine. They also activate the potent T follicular helper cells, and also this lead to the maturation of the antibodies and long-term immunological memory. And this is by giving although the efficacy of an mRNA vaccine reduces to about 50% after 1 year, by giving a booster dose, it will reactivate the efficacy due to this effect, potent T follicular helper cell induction. So the platform is that the vaccine platform includes a mRNA modification with M1-Cy. These modified nucleosides allow mRNA to evade some innate sensors, increasing the antigen production. And the use of the LNP as an adjuvant, that's lipid nanoparticle itself, is a primary danger signal, because this nanoparticle embedded mRNA will produce a more more triggered release of pro-inflammatory cytokines like IL-1 beta and IL-6, and this reactogenicity after taking the vaccine is being considered to be equated to the efficacy of the vaccine. That's the common side effects after COVID vaccine administration. That's the fever, myalgia, and fatigue occurs due to the innate immune activation, and this indicates that the vaccine is successfully engaging the immune system. This primary impact due to this vaccine, they had led to a 90% reduction in the COVID-19 associated invasive mechanical requirement and hospital deaths, in-hospital deaths. And the unvaccinated status is a key independent predictor for ICU admission. So even though the COVID has emerged from to Omicron and other variants, this 3 doses of vaccine maintained 94% effectiveness to prevent the patient going into invasive mechanical ventilation or death of a patient. And although it wanes over time, the vaccine efficacy is being increased by booster doses after 1 to 2 years. There's also a vaccine filter effect with breakthrough infections in patients who are already vaccinated. Significantly, this occurs in a vaccinated patient who comes to the ICU, especially in older patients and who have a much higher burden of severe chronic comorbidities and also who are immunocompromised. So the ICU challenge has been now to a high volume viral ARDS to a lower volume of high complex patients where COVID is the acute incident. That is, the volume of the patient has been reduced, and who will come with say, infection after vaccination will be having a significant viral load, and who are immunocompromised or having a higher age. Especially immunocompromised patients who are worse responders are these patients with solid organ transplantation who have a vaccine efficacy of as low as 59%, especially using antimetabolites like mycophenolate. And poor responders are patients with hematological malignancies, especially B-cell depleting therapy like rituximab. The strategy to augment protection is a 3rd dose supplemental vaccine, especially after 1 year booster dose. Coming to the adverse events of this mRNA vaccines, the main adverse event is the myocarditis and the pericarditis. This occurs in young adult persons after 2nd dose. The pathophysiology behind that is a transient hyperinflammatory response and not a sustained autoimmune attack. Anaphylaxis are very rare, less than 5 cases per million doses, and there are no absolute contraindications. Risk-benefit analysis, the benefit of the vaccination preventing COVID-19 is far more than outweigh the smaller risk of adverse events. So if at all myocarditis occurs, the myocarditis following a severe SARS-CoV-19 infection will be much higher than the post-infection myocarditis, post-vaccination myocarditis. So post-infection myocarditis often substantially more severe than post-vaccination myocarditis. So it's better to take the vaccine than getting and contracting an infection without vaccination. So another is the unprecedented speed with which we can develop the vaccine in respect regarding the mRNA vaccine, because if the viral sequence is identified, the vaccine could be made within less than 1 year, that we have seen in the COVID-19 outbreak. And there's from a reactive posture to the proactive one. That's reactive posture to lockdowns and crisis in ICU to a proactive one with rapid immunological containment has occurred due to mRNA vaccination. The ICU's role is also redefined. It was overwhelming patient load was there due to multiple cases. It has turned to a post-mRNA era, a specialized support system managing clinical complications, severe breakthrough infections in most vulnerable, rare, severe vaccine-led adverse events, and non-pandemic critical illness. So conclusion is that mRNA vaccines are a shield for ICU, which can primarily function to prevent severe disease, preserving the critical capacity. And a new future has been formed as it fundamentally reshaped the pandemic preparedness, shifting the strategic role of ICU from managing volume to managing complexity after post-vaccination infection. And the risk stratification agree, understanding the spectrum of immune response in immunocompromise is vital for patient management, and expertise in complexity, intensively prepared to manage the comorbid breakthrough infections and diagnose rare vaccine-related adverse effects early after post-vaccination. These are the conclusion. So mRNA vaccine is a boon in a future area for a coming pandemics because of the successful rapid development and prevention of mass casualties or mass ICU admissions due to a pandemic, but have to be cautious with the ones who are immunocompromised getting the vaccine to be more sick, and also we should also be alerted regarding the adverse effects pertaining to the vaccine, although the adverse events occurrences are very less compared to other vaccines. Thank you.
Thank you, Dr. Vivek, for a detailed presentation. Do we have any
Thank you.
questions to Dr. Vivek? Dr. Pranshita, are you ready with your slides?
Ma'am, you have to unmute yourself first.
Yeah. I've shared it showing the whole present webinar.
Right now, can you please
Someone
share?
else is,
Ma'am, can you share right now?
yeah, I'll share again. Yeah, I'm not able to.
Okay.
We can open, I think it will just waste time. Yeah.
Have to go to the slide.
Sure.
Next. Can you see your screen, ma'am? Dr. Pranshita? Yeah.
Yeah, I can't see the screen. Wait.
Now, if you come to the Zoom. Please come to the Zoom screen, which is blue in color.
Yeah. Yeah, can I start? I think,
Yes, please.
yeah. Okay, so my first topic is stem cell therapy in sepsis and ARDS. So I'll be covering this under the following headings: pathophysiology of ARDS and sepsis, mechanism by which stem cells help and what are the cells that can be used, evidence so far, and challenges and limitations. So so pathophysiology in ARDS and sepsis. So we all know that there is in ARDS, there is a alveolar damage, there is a loss of alveolar capillary integrity, neutrophil driven inflammation, and impaired gaseous exchange. And the new definition of sepsis, which says that sepsis is basically a dysregulated immune response to the injury. Basically, it is a dysregulated immune response to the infection, and it involves endothelial injury, microcirculatory collapse, and multi-organ dysfunction. So because both these conditions have a high mortality, so they have a limited specific therapies, making them good targets for regenerative and immunomodulatory strategies. Now the next slide. Now this slide, basically we can, this is the main slide, which is, which explain the pathogenesis of sepsis, and it is the basis for all the immunomodulatory agents which can be used in sepsis. So basically sepsis is an interplay of the inflammatory response and of an anti-inflammatory event. So because of both inflammatory and anti-inflammatory events, there occurs sepsis. So in the innate immunity, the interleukins and the complement system takes part, and the cellular responses mainly by the activation of the B cells and the neutrophils. And in the adaptive immunity, basically there is stimulation of the plasma cells and production of the immunoglobulins. And in the anti-inflammatory response, PAMs and toll-like receptors play a role, and when when the patient is prone for more nosocomial infection is when there is a decrease in there is a immune paralysis, which basically occurs due to T cell exhaustion and apoptosis of the immune cells. So this is the basis for all the immunomodulatory agents which can be used in sepsis, and one of them is stem cell therapy. Next. So now next heading which we need to remember is how these stem cells will help. These are the potential sources of the progenitor cells, that is the lung epithelial progenitor cells, the embryonic stem cells, and the induced pluripotent stem cells which are obtained from the skin. Then the most common one is the mesenchymal stem cells. These are the ones which are most commonly used in sepsis and ARDS, which are obtained from the bone marrow, and the endothelial progenitor cells which are obtained from the blood. Next. So how does it help? In both the conditions, basically these stem cells act in both autocrine and paracrine manner. Autocrine is that it will regenerate, the cell will regenerate itself and multiply itself, and paracrine means it will release cytokines and stimulate the other cells to grow. So in ARDS and sepsis, paracrine is the main mechanism by which these stem cells help. So how do they help is, first is immunomodulation. We know main pro-inflammatory is TNF alpha, and anti-inflammatory, which we need to remember, is interleukin 10. So it will increase the interleukin 10 levels and decrease the TNF alpha levels. It will produce antimicrobial effects by increasing the phagocytosis. Then barrier protection by stimulating more cell production and releasing VEGF and so that and other growth factors for repair and angiogenesis. And the new mechanism through which they act is exosome and mitochondrial transfer, and all of these will lead to improved oxygenation. So these exosome mechanism is presently being studied currently. Next slide, please. Yeah. So what are the evidence? So obviously the animal models have shown that there is a strong biological plausibility of using these stem cells, and only for the stem cell therapy one has to remember START trial. So phase 1 and phase 2, both of them have occurred, and 2B and 3 are still undergoing, they are ongoing phase. So there have been no mortality benefit, but both of them have shown that the stem cell therapy has shown to increase the oxygenation and decrease the epithelial injury. And in COVID-19 ARDS also, they just included 7 severe ARDS patients, and same, there was no mortality benefit, but there was improved oxygenation, but it was in an underpowered study. So these are the evidence. So stem cell START trial which needs to be remembered. Next. Now, what are the limitations of the stem cell therapy? So there are biological limitations, limitations related to safety, limitation related to the clinical evidence, logistics, and social or ethical. So biological would be that uncertainty about the engraftment and survival of the graft. As I told you, that mechanism is mainly paracrine, so that's not a true regeneration, and donor variability and heterogeneity. Safety would be definitely in cases of embryonic stem cells and this induced pluripotent cells, which can lead to an increased risk of tumorigenesis. And yes, definitely small underpowered trials are there, so there is no consistent mortality benefit, as you have seen, and there is a high cost associated with it and ethical issues with it. So that's all for the stem cell therapy. So these are the main headings, and I think the second slide which I've shown, that how the immunomodulation is helpful and the agents, so that can be used for all the immunomodulatory agents. So next, I'll move on to the next topic, that is aerosolized antibiotics and antifungals. Now, main thing we have to remember is that we should know the indications, the delivery systems, and the evidence and limitations. So what are the indications for aerosolized antibiotic? So first is VAP-HAP due to MDR gram-negative bacteria. That is especially when only, when the MDR organism is sensitive to aminoglycoside and polymyxine, then only there is a IDSA V and ATS 2016 weak recommendation to use it as a salvage therapy in case of non-responder to systemic antibiotics. In case of tracheobronchitis, definitely, ma'am, next slide. It is showing still on the stem cell. Yeah, next. Yeah. So indications I've already told. The first one, that is VAP-HAP due to MDR gram-negative bacteria as a salvage therapy. In case of tracheobronchitis, it might reduce progression to VAP and as a prophylaxis in high-risk ventilated patients. So in this trial with inhaled amikacin, which occurred recently which has been done recently in 2023 and published in NEGM, it was amikinhal trial, and in which around 20 milligram per kg or per day of aminoglycosides was given through inhaled route, and they found around 30% reduction in the mortality in case of aminoglycoside group, 30% reduction in progression to the VAP. So they just gave this inhaled aminoglycoside to the patients who were ventilated for more than 3 days, basically on mechanical ventilation. So the limitations of these trial, as it is a recent trial, so one must know about it, that the definition of the VAP becomes tricky when inhaled aminoglycoside is used, and they could not find any difference in the mechanical ventilation duration. And about resistance issues are there, because in this trial only the amikacin was used only as a prophylactic. They just saw whether it would progress to VAP or not. Next slide. Yeah. So next is, so after indications, next is delivery system. So one must know what are the factors which help in effective delivery of the aerosol drug. So when a mechanical ventilated patient is there, slow flow of 40 liters per minute, long inspiratory time, NIV with nebulizer, PEEP, and for tracheostomy, if the patient is tracheostomy, use TPs, and obviously we have to remove the HME. And definitely prior to the nebulization, one must, bronchodilation and clearing of the secretion should be done. And as we know, the particle size which can reach the alveoli is less than 5 micron meters. So particle size of 2 to 5 micron will help in the effective drug delivery. And in non-mechanically ventilated patient, slow deep breathing pattern and the same size of the particle can help. Next. Now, what are the ventilatory parameters? The nebulizer which you have to place for the effective drug delivery of the aerosolized antibiotic is in the inspiratory limb, 10 centimeter proximal to the Y-piece, diluted in the 10 ml. Obviously, you have to remove the HME filter to avoid clogging of the filter. Volume control mode and constant inspiratory flow would definitely help. A longer inspiratory time and a respiratory rate of 12 is good enough. And there should be an end inspiratory pause for the dissipation of the drug, and should be delivered over 60 minutes. Next. Now, what are the nebulizers which can be used? Jet, ultrasonic, and vibrating. Now, jet is the one which we are using most commonly in the ICU, which basically uses the Venturi effect. And it is easy and it is less costly, and that is why it is used. But the thing is, it is difficult to clean, inefficient, because as you can see, the droplet size which reaches through the jet is more than 5 microns. So less than 5 only to the ultrasonic, it does not produce any noise and it is very small. But the only thing is cost issues and cleaning issues with this. And obviously the dose which we will use for the jet and the vibrating mesh has to be different. The least preferred nebulizer is the ultrasonic one, which uses the piezoelectric crystals. As it is a very larger size, it makes a lot of noise, and it cannot be used for heat sensitive antibiotics, because it will the heat will degrade the proteins. And it will not be able to, we cannot use viscous solutions also with this ultrasonic. So this is the least preferred. Jet is what we are using most commonly. Vibrating mesh is basically what needs to be more commonly used. Next. Yeah. So basically now let's talk about the third part. We have discussed about the indications, how the delivery, what are the factors which are effective for effectively delivering the aerosols, what should be the mode and where it should be placed, the 3 type of nebulizers, which is the most common one, which is the least preferred, and which is the upcoming one, and now is the evidence. So basically the meta-analysis have shown that definitely aerosolized have increased the microbiological eradication when added to IV therapy. And this was published recently in Critical Care. But and only there is a small advantage when we are talking about clinical cure in case of MDR VAP, but there is no significant reduction in the mortality. And even if you talk about aerosolized antibiotics or antifungals, mainly the adverse effect is bronchospasm, sore throat. Systemic toxicity is definitely not increased. So there is a weak recommendation only for MDR gram negative pneumonias, which is sensitive to aminoglycoside or polymyxins. And this we have to remember is ATS ITSA 2016 says this. So what are the limitations? Next slide. Yeah, limitation is with what will be the best dosing for the inhaled agents, which specific agents are optimal. Till now, aminoglycosides, colistin have been tried. What should be the standardized delivery method? As I told you about the various nebulizers which we are using, whether inhaled antibiotics can reduce the duration of IV therapy or hospital stay in a meaningful way or not, long-term risk of lung toxicity, and selection of resistant organism locally, and the cost effectiveness in resource limited settings. So next is aerosolized antifungal. In case of aerosolized, I'll discuss this only under 2 headings: indications and evidence and adverse effects. So indications are, next slide. Next. Yeah, next slide. Yeah. So indications of the aerosolized antifungal is that basically the antifungal which has been till now used is inhaled amphotericin B, and azoles have been tried, but not with a very promising benefit. Inhaled amphotericin B has been used in lung transplant patients as a prophylaxis for aspergillus, and this is the strongest evidence. So this is the one which we have to remember, that this is the one which is the recommendation for inhaled amphotericin B according to the ITSA. And even in severely neutropenic patients to prevent aspergillus, it has been used. Apart from them, the rest of the indications are just experimental. So that is, in case of COVID-19, it was used for prophylaxis, and again, no mortality benefit. In case of influenza associated aspergillus, pulmonary aspergillosis, again, limited benefit. Then in case of airway limited aspergillus or tracheobronchitis, and also it has been used in refractory invasive aspergillosis. So in all these conditions, it has been used, but main important indication which we need to remember is in case of lung transplant patient prophylaxis, and in severely neutropenic patients also. inhaled ampho B has been used for prophylaxis against aspergillosis. Next slide. Yeah. Amphotericin, deoxycholate form and liposomal form both have been used. Deoxycholate is used once daily, and the liposomal form is used in the dose of 12 to 25 milligram twice to thrice weekly. Now, these are the the adverse effects of any aerosolized is same, that is sore throat, cough, bronchospasm. That remains for common for both antibiotics as well as for antifungals. So the clinical the issues which or the controversies regarding these aerosolized antifungal is that whether they can be used for cavitatory lesions or not, or they can be best used for primary prophylaxis or secondary prophylaxis. And with the lipid formulations, is there any concern for fatty infiltration in the lungs, or these are all the limitations which are there. So, and whatever studies have used aerosolized antifungal, they have recommended to use vibrating nebulizer. And the dose I've already told you. For deoxycholate, it is 5 to 10 milligram OD, and for liposomal, it is 12 to 25 milligram twice or thrice weekly. That's all. Next. Yeah, third topic is tranexamic acid in critical care. So next. Yeah, so I would cover it with firstly with the mechanism of action, then evidence with indications, controversies and adverse effect, and what is the current consensus and on timing and dosing. So next, as we all know, yeah, tranexamic acid is a lysine analog. So this is how the fibrinolysis process takes place. The plasminogen activator binds to the blood to the fibrin through the lysine binding site, and the plasminogen is converted to plasmin, and then there is a fibrin degradation product formation. So when tranexamic acid, it is a lysine analog, so it will inhibit the binding of the plasminogen activator to the clot, and there will be a competitive inhibition, and so there will be no fibrinolysis. So this is how antifibrinolytic action of tranexamic acid occurs. So you can even draw this diagram for and convey the mechanism. Next, and tranexamic next. It has a half-life of 2 hours and is minimally metabolized in the liver. 95% is excreted unchanged in the kidney. And as the plasma creatinine levels increase, there is a decrease in the urinary excretion of the tranexamic acid. So dose adjustment is required in patients with renal impairment. So after this is what we should know about the mechanism and little about the metabolism of the tranexamic acid. So next we'll move on to what are the indications. Next. So mainly the promising indications are in case of trauma patients, where there is a definite reduction in the mortality, and it was by the CRASH-2 trial, that is clinical randomization of antifibrinolytic in case of severe hemorrhage. That was CRASH-2, and in which 1 gram was given in the first 10 minutes, and then 1 gram over the next 8 hours. So you just have to remember that tranexamic acid, the optimal dose which is required is 1 gram in the initial, and in whatever benefits, it has to be given within 3 hours of the setting. So whether it is a trauma setting or obstetric setting, we have to give within 3 hours. So second is obstetric pathologies. This was by basically proven by women trial, which showed that there is definitely a decrease in the PPH mortality when you give within 3 hours of setting of the onset of the bleeding. And in case of scheduled surgeries like orthopedic surgeries, like especially TKRs or gynecological surgeries or cardiac surgeries, you can they definitely decrease the blood transfusion requirement, but that is not a very proven, that is a questionable benefit. So proven benefit is only 2 of tranexamic, that is trauma and obstetric, which I've shown through thumbs up, and the query 1 are scheduled surgery. And next is in TBI, unclear for mild to moderate, not in severe TBI, which was shown in the CRASH 3 trial. So, and in cases where you don't have, where Tranexa is not indicated, is in case of gastrointestinal bleeding. I'll come to the halted trial which showed that, and in case of intracranial bleeds. Next. Yeah, the major trials. First is the CRASH 2 trials. I've already told that in case of bleeding trauma patients, 1 gram is given over 10 minutes, and then over 8 hours, 1 gram infusion is given. Within 3 hours is what you have to remember in Tranexa. There was a decrease in 28-day mortality. And main concern with Tranexa is veno-occlusive events and seizure. So there was no increase in this VOE is veno-occlusive event. So there was no increase in that. CRASH 3 is basically it is for head injury patients, and CRASH 3 showed there was a decrease head injury deaths, but that was only in case of mild moderate, not, which was again questionable. In severe head injury, no role of tranexamic acid. Women trial, I told you, was basically focused at PPH mortality, and it showed benefit due to decrease in the mortality in bleeding by giving tranexamic acid. Halted trial was basically used in GI bleeding, and they used very high dose, 1 gram followed by 3 gram. And so probably they got more of adverse effects like veno-occlusive event and increased seizures. And the last is the patch trial, which was basically patch trial supported CRASH 2 trial. It was used in pre-hospital setting, that 1 gram given within 3 hours of trauma as a bolus and then as an infusion. And it definitely decreased early bleeding death, but they could find that there was an increased risk of DVT in these patients. Next. So basically, what are the adverse effects? Main two, vascular occlusive events and seizures. So there was obviously in trauma patients in which there are definitive, benefit of Tranexa. In trauma, in obstetric, there was no increase in these events. And in case of patch trial, there was an increase in incidence, but of vascular occlusive events, but explanation of why it was increased is not very clear. Halted trial, I told you, it was for studying the role of or efficacy of Tranexa in case of GI bleed. They could not find any evidence of Tranexa, any beneficial effect. Instead, they could find that there was an increase in the veno-occlusive event, and this could be because of higher doses which they used. Seizure. Now, Tranexa, being as a lysine analog, it also binds to GABA and glycine receptor. So that is why, as you know, GABA and glycine, they are inhibitory neurotransmitters. So there is a increased seizure potential with tranexamic acid, and that is dose dependent. If bolus is more than 50 mg per kg are given, it can lead to decrease the seizure threshold and can lead to seizures. Next. So basically, consensus is decreases bleeding in trauma, CRASH 2. In TBI, only in mild, moderate, no role in severe. In PPH, women trial. In all the cases, timing is very important, less than 3 hours, 1 gram, and for over 10 minutes, then 1 gram infusion over 8 hours is the dose, which has found to be beneficial. And no increase in the vascular occlusion in large RCTs have been found. Increased seizure threshold is there when you give in higher doses, and more DVTs as evidenced by patch trial. Next. So this is all about Tranexa. Yeah, so this is my last topic, that is the liver purification systems. So basically, the liver purification systems are categorized into artificial and bioartificial. So artificial are the one which use the renal replacement technology, as well as they use a adsorbent capacity, AD, that is a surface area property. technology which uses a surface area property, so adsorbent capacity. And bioartificial systems are the one which use basically living hepatocytes, which are incorporated into a extracorporeal circuit, and they will, when you are using a living hepatocytes, it will provide both metabolic and synthetic function. So in the artificial system, the artificial ones are mainly albumin based. So in the artificial ones, the examples are MARS, that is molecular adsorbent recirculation system, ADVOS, advanced organ support, then single pass albumin dialysis, Prometheus. These are the artificial. And for the bioartificial, you just have to remember assists. So 3 names in bioartificial and 4 in artificial. So mainly we will talk about MARS and ADVOS next. So what are the main next? What are the index to potential symptomatic reality? So we'll talk about modern system. And this circuit, the blood will be obtained from the patient. Then this will go through a albumin dialyzer. The albumin dialysate will bind the albumin bound will bind to the protein bound toxins and remove all the albumin bound toxins like bilirubin, bile acids, amino acids, tryptophan, fatty acids. Then what happens is, now the purification process is only this much. The lower part of the circuit, as you can see, is basically for the dialysate regeneration. That will be through activated charcoal column, which will remove the lipophilic toxins and the remove some part regenerate. Then the regenerated albumin dialysate will again recirculate, and the conventional dialysis will occur, which will remove the water soluble toxins like ammonia, urea, creatinine, and purified blood will be returned to the patient. So this is how MARS acts. So there is a albumin dialyzer, then a dialysate regeneration occurs through a charcoal column and an ion exchange resin, and then the regenerated albumin dialysate is regenerated. So, and in turn, we'll obtain a purified blood which will be free of albumin bound toxins as well as free of water soluble toxins. So next, now what are the indications and what is the evidence for this MARS? It has been used in acute on chronic liver, in case of acute on ACLF, that is acute on chronic liver failure. Then in case of acute liver failure, as a bridge to transplant. In case of hepatic encephalopathy, in hepatic encephalopathy, so 2 names you have to remember in case with regards to MARS. One is relief trial and the other is FALMA trial. Both of them, relief trial was used in case of ACLF, and it was found to decrease the HE grade, which I have highlighted in the 4th indication. And the FALMA trial was used in case of ALF. In case of acute liver failure due to paracetamol, it was tried. None of them, in none of these indication, mortality benefit has been seen. Just there was an improvement in case of decrease in the bilirubin levels or improvement in encephalopathy. That's all. That was the main crux of all these trials and the indications for which MARS has been used. Next. So next is the advanced organ support or ADVOS. Now, in case of ADVOS, what happens is the blood is taken from the patient, and then this blood is passed first through a high flux filter, which will remove all the water soluble toxins, and then it will go through a second circuit, that is the albumin solution, similar to Mars. Here also the blood will pass through a albumin based solution. So when blood is passed through albumin based solution, it will remove the protein bound toxins. Then what will happen is it will pass through a third circuit. Now this is the circuit which is different in the ADVOS system. What is the differences? That instead of the charcoal, activated charcoal, which you saw in the Mars, the third circuit is using basically a pH and a temperature based dialysate system to regenerate the dialysate. So this is how Mars is different from ADVOS. So there, after passing through the albumin, it was going through the exchanger resin, and then the dialysate was getting regenerated. Here it will albumin will be regenerated by changes in the pH and temperature of the dialysate. And also it will provide changing the pH and CO2 balance. It can provide other organ supports also, like correction of the metabolic acidosis or respiratory function. So this is how ADVOS is different from Mars. So next slide, please. Yeah, so this is the main difference between ADVOS and Mars, that the charcoal resin columns are replaced by the change in the pH and temperature for the regeneration of the dialysate, and there is a multi-organ support. So last slide. So this is next slide. So this is so this is basically the comparison. Everything you can see is both of them are albumin based, both will remove protein and water soluble toxins. But here there are adsorption columns. That is why name is molecular adsorbent recirculating system. And here it is just a pH and temperature shift. Then Mars will only provide a liver support, but ADVOS can definitely provide multi-organ support because of this CO2 and pH changing system which it has. So yeah, that's all. Thank you.
Thank you, Dr. Pranshita.
Welcome, sir.
Okay. Lastly, I'm doing some presentations. I'm sharing my slides.
Unni and all other people, hi.
Yes, sir.
Arindam here. I'm extremely sorry. We have had some dire emergencies that had happened. Unforeseen events had happened, so I was not been able to join. But I'm here. Please carry on the good job. Excellent presentations, and everyone is giving the good feedback. Please carry on. I'm here. I will conclude the session.
Thank you, sir.
Thanks.
So we are in the last lap. So I'll be discussing some of the newer antifungals, which include Fosmanogepix, Ibraxa fungerp, then the other two, Olorofim and Resafungin, I have not put in. Just go and read because those were also asked in the prior DRNB exams. First is Fosmanogepix. Even though it's a tough name, you can remember when I tell about the mechanism of action. It is like colistin, it comes as a prodrug. Fosmanogepix, it's acted upon by the systemic phosphatases in the body and get converted into.
I'm so sorry. Yeah, I'm so sorry, sir. You have to do full screen and you have to share your presentation properly. Like, it's not shown properly. It will do full screen, sir.
No, is it full screen?
So, you see there's a reuse slides, there's a cross mark. Please put a, no, sir. There's a cross mark on the right-hand side.
Cross
So
mark.
there's a small cross mark which is
Play from current slide.
written as
Yes.
reuse slides. Right, sir. No, right. So there's a reuse slides. Can you see that?
You mean that scissor kind of emblem? Cut.
So do the
Which emblem you are saying?
Yeah, so right hand side, sir. Just go on the top. Go top. So
Where?
right hand side, sir. Move right. Go below, a little below, little below, little below. So here you see reuse slides. It's written
Reuse.
reuse slides.
Yeah.
Yeah, cross that. Slides. Just cross that.
It's closed.
Yeah. Now you do a full. Yeah. Now you do a full screen.
Okay.
The screen is not full screen, so you have to do full screen right now.
Now is it full screen?
No, it's not. So you go to the menu.
Menu.
Okay. Go to slideshow. Sorry, sir. Just come out of that and just go to slideshow.
This one, no?
Yeah. Yeah. No, what is this? The
Still
full screen is not coming actually. No, there's no full screen option which is coming.
Shall I complete the presentation in view of lack of time?
Yeah, sure.
So in the fungus, you have inositol, which is converted to GPI anchor, which is glycosyl phosphatidyl inositol, which is acted upon by GWT1 enzyme. It is on this particular enzyme that this manogapics act. This enzyme is being inhibited by this manogapics. What does this enzyme do? Actually, within the fungus, there are a lot of these manoproteins, these red colored structures called manoproteins. This anchor helps in binding of these manoproteins to the host cell. So once this drug is being given, these manoproteins have become dysfunctional and help in alteration in shape and morphology of this fungus. Actually, that's how it acts, by destroying the fungus. The advantages of these newer antifungals is that they like the broad spectrum antimicrobials. They could be used in Candida, Aspergillus, and all whatever be the antifungal. If the patient carries any risk factors for any fungal infections, you can use this. Whereas our available agents, like if you Aspergillus, you can use voriconazole, Cryptococcus amphotericin, be like that. So as a broad spectrum empirical inhibitory dysfunctional. And the phase 1 and 2 trials are well tolerated with minimal adverse effects, and there is no nephrotoxicity, and the dosage is actually interesting. It is given as 1 gram IV twice daily on day 1, followed by 600 milligram once daily IV for 2 days, followed by 800 milligrams as a tablet orally. It has shown 80% success rate, and it has shown demonstrated good synergy with amphotericin B for the treatment of difficult to treat resistant fungus. And the ongoing trials are Apex study, which is ongoing in Candida auris, and Aegis study and in Aspergillus and other molds like Fusarium and Rhizopus. And FDA has requested for fast tracking for the early availability of this drug, because we know the lot of oncologies in the advanced, lot of cancers are being diagnosed, lot of chemotherapeutic drugs are being used. So the fungal infections are actually on the rise. So the next one is Iprexa fungar. I know the term is difficult to pronounce. We know echinocandins in the fungus, the cell wall is composed of beta D glucan multimers. It is a beta D glucan synthase enzyme that helps in synthesis of beta D glucan. It is this enzyme that the echinocandin inhibits. It is on this particular same enzyme that this particular drug, Imprexa fungar, also act, but the binding site is different compared to an echinocandin. So Iprexa fungar packed by inhibiting the 1,3 beta D glucan synthase enzyme complex, thereby inhibiting the cell wall formation. It is for Candida, it is fungicidal, whereas for Aspergillus, it is fungistatic. it is 99% protein bound and the bioavailability of 35 to 50%. And it inhibits the usual cytochrome P2C8 and cytochrome P3A4 and attains peak concentration in 4 to 6 hours. Since the half-life is 20 to 30 hours, once daily dosing is enough. And the spectrum of activity, it has good activity against azole-resistant candida like Candida glabrata cruzi. Even for echinocandin-resistant organism, candida, the effects are variable. It has a good activity against Aspergillus also. Phase 1 and 2 trials have shown no much serious adverse effects, and the ongoing trials are Fury trial and the Skynergia trial. In Skynergia trial, ibrexafungerp was added on with isavuconazole, which has shown increased efficacy and safety against Aspergillus. And the potential indications are Candida auris, azole-resistant mold infections when you combine with amphotericin B, and as a prophylaxis for Candida and Aspergillus. Next is extracorporeal carbon dioxide removal. We know it is a technique that whose objective is the decarboxylation of blood and thus to correct the hypercapnia and the respiratory acidosis. It is similar to ECMO but uses slower blood flow. So it is also known as ECMO. The blood flow rate is usually less than 1.5 liters per minute. So this since the blood flow rate is less, this technique has little or no impact on blood oxygenation. So initially, this was developed in the treatment of patients with severe ARDS, where we do permissive hypercapnia. So to wash out the increased, to permit ultra lung protective ventilation and help in wash out of this extra carbon dioxide, it was used. But now it has been proposed as a therapeutic option in hypercapnic respiratory insufficiency and severe decompensation of COPD or in ARDS to achieve less invasive mechanical ventilation so that the ventilator-induced lung injury can be minimized. So this chart showing if the patient has a only hypoxemia and there is no circulatory compromise, we know only a veno-venous ECMO is required. If the patient is hypoxemic with shock, mostly in ARDS with shock, the cause of this shock could be RV failure. So in this condition, we may need to use VA ECMO or VAV ECMO. And if the patient has hypercapnia with hypoxemia, VV ECMO, hypercapnia without hypoxemia, VV ECHO. So only type 2 failure, is refractory type 2 failure is the indication for performing ECHO. So in many expert centers, the devices used to provide ECMO and ECHO support are the same. And given that the key difference is blood flow rates, there is considered overlap between the two techniques. So we know the oxygenation of blood and removal of carbon dioxide are physiologically different. Oxygen is actually mainly transported bound to hemoglobin rather than being dissolved. And the mixed venous blood generally has high oxygen saturation, which limits the amount of oxygen per liter that can be added to the blood perfusing the natural or the extracorporeal lung. This makes the blood oxygenation dependent on blood flow. Whereas the carbon dioxide exchange depends on ventilation, the minute ventilation. So here it is for an extracorporeal circuit, it is mentioned in terms of sweep gas flow. The sweep gas actually contains little or no carbon dioxide. This gas that is passed.
Excuse me, slides are not changing.
Slides are not changing.
No.
Now is it changing?
No, it's not stuck in the. Now it's changing. Now it's changing.
Okay.
Okay.
The actually ECHO systems vary in characteristics, technology, and the ability of gas exchange. They range from even with a renal CRRT machine, we can do this ECHO, and with a full ECMO machine also we can do ECHO. And actually an ECHO circuit consists of like a VV or a V ECMO, percutaneously placed drainage cannula, which is either placed in a large central vein, which is followed by a membrane lung and a return cannula, which enters into the venous system. In case of an AV system, the patient's blood pressure actually provides a driving pressure across the membrane. The veno-venous systems require a pump to be placed within the circuit. This is an image wherein we perform a VV ECHO. Here the drainage cannula is in the right femoral vein. The blood is drained. Since it is from a vein, it needs a negative pressure which is provided by the pump. And in this equipment, we are providing carbon dioxide removal. And after, once the carbon dioxide is removed, it is return to into the internal jugular vein. This is a AV form where if the patient has a circulatory involvement also, the blood is drained from the femoral artery enters the artificial lung, and after this, in this situation, there is no need for a pump because it is from the artery we are drawing, and it is returned into the vein. So, as we all know, the key disadvantage of an AV approach is the need for an arterial cannulation. So, all potential side effects of arterial injury and limb ischemia we need to take care of. So, the cannula size has to be appropriate, and the cannula for central venous cannula also, like all for venous cannulation, we are cannulating with 19 French and 21 French. So, a high risk of damage to blood vessel and surrounding structures like pneumothorax or arterial injury could happen. In regards to the membrane, on non-microporous polyformethyl-1-pentene, PMP is used, and it provides superior gas exchange, better biocompatibility, and lower resistance, and is less susceptible to plasma leak. Modern membrane lungs achieve adequate gas exchange with surface areas of 1 to 3 meters square. The gas exchange membrane is connected to air or oxygen, which acts as a sweep gas, which contains minimal carbon dioxide, which helps in removing carbon dioxide that is diffused out of the patient's blood. And the flow rate of oxygen is increased in a stepwise fashion up to a maximum of 12 liters per minute. So, to achieve maximum carbon dioxide excretion. And early clinical trials did not show positive outcomes, and the complication rates were much high. And in 1980, Gattinoni et al. Showed that ECMO with a blood flow as low as 1.3 liters per minute drastically reduced ventilation needs, thus limiting ventilator-induced lung injury. And more recent studies have showed that PaCO2 can be reduced and arterial pH improved using ECOR. And an ECOR has also been shown to reduce minute ventilation in an uncontrolled cohort of 159 patients over the last 10 years. And it has been shown that 1/3 of patients receiving lung protective ventilation had evidence of tidal hyperinflation and hence lung injury. So, although permissive hypercapnia has been advocated, hypercapnia may cause significant physiological instability, including pulmonary hypertension and RV failure, leading to a global low cardiac output state. So, in these patients, the addition of ECOR may allow control of hypercapnic respiratory acidosis and facilitate ultra lung protective ventilation, thereby limiting end inspiratory lung stretch. In severe COPD exacerbations, high airway resistance, VQ mismatch, dynamic hyperinflation, and increased work of breathing with increased carbon dioxide production lead to hypercapnia. Given the outcomes of these patients requiring mechanical ventilation, its avoidance in this population is of potentially of clinically benefit. So, for this reason, ECOR is being considered as an adjunctive therapy to NIV to facilitate the withdrawal of NIV, avoid intubation, or facilitate early extubation. So, this is the article supporting the maybe you could avoid intubating this patient and put on an ECOR device early on so that to safeguard the lung, preventing the lung injury. In summary, the arguments for ECOR in exacerbations of COPD are compelling, although the evidence remains weak, relatively weak. Further evidence is required. In patients who are failing NIV and who do not want intubation but also do not want palliative care, ECOR seems a reasonable approach. And you could consider this in those who are awaiting a lung transplant who develop life-threatening hypercapnia. So lastly, to conclude, technological advances in ECOR, together with the recognition that ventilator-induced lung injury can occur, have created the opportunity for an extended role of partial ECOR. Future applications will involve smaller and more biocompatible ECOR systems for patients with moderate to severe ARDS, but also as a sole supportive modality in patients with hypercapnic respiratory failure. And the potential complications of ECOR need to be evaluated when the patient considering for extracorporeal support. Shall I continue or should we?
Sir, up to you.
Okay, I'll brush up fast.
The next is, sir, yeah.
I'll brush up fast. Next is immunotherapy in sepsis. We know sepsis has different phases. It is a dysregulated host response to infection. So we have the hyperinflammatory phase and the immune paralytic phase. So it is an immune paralytic stage. So we need to modulate this response and dampen the harmful inflammation early. So to approach these immunomediators, there are various key immunotherapeutic approaches are there. Like first is cytokine adsorption, whereas extracorporeal removal of pro-inflammatory cytokines, it was mentioned by Dr. Pranshuda. It was met with mixed results. Small RCTs showed improved hemodynamics, but no consistent benefit on mortality. Next is anti-cytokine antibodies like anti-TNF alpha, anti-IL-1 and anti-IL-6. They block key inflammatory mediators. Again, has not shown much benefit on mortality. Obviously, the corticosteroids, we have low dose hydrocortisone, 200 milligram daily, plus or minus fludrocortisone. It is supported by adrenal approaches trial, and we know it helps in faster resolution of shock. You can use it in vasopressor refractory shock. IV immunoglobulin, standard, it helps in neutralizing the endotoxin. We know gram-negative septicemia is the most common form of sepsis we encounter. It helps in neutralizing the endotoxin. But it has been shown that standard IVIG is not beneficial. Actually, IgM-enriched IVIG shows signal in some meta-analysis, though not definitive. The GM-CSF reverses sepsis-induced immunosuppression. So we have only small data that has shown improvement in leukocyte function, but no clear benefit on mortality. IL-7 helps in restoring the number of lymphocytes and functions. IRIS-7 trial has shown increase in lymphocyte counts, but larger outcome trials are ongoing. And checkpoint inhibitors like anti-PD-1, anti-PD-L1 reverses T-cell exhaustion. It also in the beginning stages of trials. And mesenchymal stem cells helps in anti-inflammatory and tissue repair. Preclinical trials are underway, and early human trials are underway. Vaccines or trained immunity helps in enhancing the innate immune memory to prevent secondary infections. Still experimental. So, should we practice? It's still the immune therapy is still in its infancy. It is not routine except for low dose corticosteroids for refractory septic shock. So, as usual, go to the baseline, do the appropriate source control, appropriate antibiotics within 1 hour. Supportive care remain the cornerstone, and other modalities should be considered only in clinical trials or in specific scenarios, such as in hemadsorption with cytokine storm with ECMO and high IL-6 states. Future directions, it has to be precision medicine, tailor-made to each particular patient. Biomarker-guided therapy to identify hyper versus hypo-inflammatory patients. Combination therapies targeting different immunophases. Personalized dosing or timing. Example, early anti-inflammatory or later immune stimulatory agents. So, whenever we use these agents, we should be in that phase where we are washing out the anti-inflammatory cytokines and not the pro-inflammatory cytokines, which help in combating the sepsis. So the key takeaway is immunotherapy in sepsis is promising, but not yet standard of care beyond corticosteroids. Most agents remain experimental and should be used in the context of well-designed clinical trials or as an adjunct in select biomarker-driven situations. So next is bicarbonate therapy in ICU. What is the evidence? We know the classical indications, the severe metabolic acidosis with a pH of less than or equal to 7.1, especially when it is the acidosis is due to renal failure, that is either an AKI or a CKD or an acute on CKD. When this acidosis is contributing to hemodynamic instability, we know it helps in the acidosis leads to reduction in SVR and increase in PVR. When there is a life-threatening hyperkalemia, which is refractory to the conventional measures. Specific poisonings or overdoses like tricyclic antidepressant toxicity, which leads to sodium channel blockade, and salicylate poisoning. Urinary alkalinization, the indications are actually relative, clinician based, rhabdomyolysis, tumor lysis, and myoglobinuria in selected cases. And what is the evidence for use in lactic acidosis? Routine use of sodium bicarbonate in lactic acidosis without acidemia is not recommended because it does not improve hemodynamics or mortality and may worsen carbon dioxide load and volume status. So what is the evidence? We have the biggest evidence coming from the BICAR ICU trial, which was published in NEJM 2018. It was a multi-center open-label RCT conducted on 389 ICU patients. The primary outcome was composite of death by day 28 or presence of at least one organ failure at day 7. So the key findings were no significant difference in primary outcome, and in the subgroup analysis, it showed reduction in primary outcome and lower 28-day mortality, less need for renal replacement therapy. So the takeaway was the benefit was confined to patients with severe acidosis and significant AKI. So as already mentioned, consider giving bicarbonate if the acidosis is related to an AKI. So start with slow infusion with a 4.2% solution guided by repeated frequent IABG measurements and volume status. And obviously monitor for volume overload, hypernatremia, hypocalcemia secondary to carbon dioxide generation, and paradoxical intracellular acidosis, which is detrimental. So bottom line, use IV sodium bicarbonate selectively, especially in ICU patients with pH less than or equal to 7.2 plus KDCO stage 2 to 3 AKI as supported by the BICAR ICU trial. We have further BICAR ICU 2 trial is ongoing. We have hopefully we'll get better answers with those trials. Next is the famous the Marek protocol, the hydrocortisone had therapy in sepsis, hydrocortisone, ascorbic acid, and thiamine. What was the rationale? Hydrocortisone actually addresses the RAI, relative adrenal insufficiency, and helps in reversing the vasopressor refractory shock. We have evidence for the same from adrenal and approaches trial. Vitamin C is a cofactor in catecholamine synthesis, antioxidant, and helps in improving the endothelial function. Thiamine helps in preventing or treating deficiency, supports PDH activity, and may reduce lactate. This concept is the metabolic resuscitation was conceptualized and popularized after 2017 before and after single-centered study by Marek et al., which reported a dramatic mortality reductions, but that has not been confirmed in later large RCTs like vitamins act. So based on this, a pooled meta was showed benefit of this HAT therapy. Possible small clinically uncertain reductions in duration and no major safety signals except for mild hypernatremia and hyperglycemia, cortico and occasional oxalate usage of high dose vitamin C. So, 20 guidelines say hydrocortisone is per day as 5 grams for septic ongoing vasopressors despite adequate resuscitation. They do not recommend CNM outside the evidence. This I already mentioned. So with this, I conclude my talk. Any doubts or clarifications?
Yes,
Sir. We are, sir.
madam, एक minute.
Yes, sir.
हाँ, मैडम मैं कॉल बैक कर रहा हूँ 1 मिनट. Yes, Unni.
Yes, sir. I can hear
Yes,
you.
hi. So I think you covered an excellent on this say with lot of good. My request would be to both the presenters and also the guiding faculty, if you can please, we are sharing the slides itself. We will post it online so that they can relook into the slides and all others. And second, also the articles that you guys have looked upon to make the presentations, if those articles are also being shared to us. So we are also collecting the articles on the same, on the topic wise. But if you can also share those articles in the group itself directly, that would be fine. But the slides, Sudeshna will coordinate itself. And thank you once again. We would work on it so that we have it is much more structured. And the same group, we will continue to work on the practical also, success P, where. But the first, our motto is to make most of them achieve success in the theory way. Also, every domain lead like you, Unni, they are providing around 10 to 12 hot topic question, which we have not covered here itself, so that those are also in the preparation list for the candidate itself. So if you can also make 10 to 12 questions, you don't have to write the answers or make up the answers, just what to read in your domain. That would be a sort of suggestion, last minute suggestion. That would be also very helpful.
Sure, sir. We'll do it.
Okay. So, Sudeshna, what is the plan tomorrow?
Tomorrow we don't have anything. Okay. We have our next classes is on Monday.
Monday.
Saturday and
Okay.
Sunday is off. Yeah. And next classes on Sunday. I
So
would
I
like
think we
to
have some time. So we would be finalizing the review articles that we would be sharing. And if you have got
Yes.
all the slides with you, please collate all the slides and start posting the video presentations and the slide along with the slides so that people can go back and read specific topics.
It has already been done. Each and every candidate has been given the login ID and password.
Okay.
I've completed the job by yesterday. And once I get the slides of today, I will upload them. Slides have been uploaded. Obviously, video presentation requires a little bit of editing, so it takes a little time. And the review articles, once I get it from Rakupati, I will collate. And we have already uploaded some which we have received. As more we get, we will upload it. So each and every candidate, they have their own login ID and password. And according to the domain, whatever is uploaded, they are able to see. It's been already conveyed to everybody's individual WhatsApp and they have acknowledged also. But only I would request you to share your slide because I don't have the slide. If you can just share, then we will upload it.
Sure, I'll do it.
Thank you.
Okay, then we'll see on Monday, right?
Monday, 6 o'clock.
Okay. Thank you and good night and good weekend. Thank you, Unni, once again.
Thank you, sir. Thank you so much. Good
And
night,
Dr.
sir.
Vivek
Thank
too.
you all
Yeah.
faculties.
Thank you.
Thank
Thank
you.
you, sir.
Thank you,
Pranshulta,
Dr. Paul.
Vivek, everyone.
Thank you, sir. Thank you.
Thank you so much. Good night.